everybody. Welcome here in Mirandola. Buongiorno a tutti e benvenuti qui a Mirandola. Parlerò in italiano, so che comunque c'è la traduzione in inglese per gli ospiti. I will speak in Italian. If someone needs the translator, you can ask at the reception. I will introduce this conference. My name is Massimo Garuti, I come from Democenter. Io sono Massimo Garuti e sono di Democenter, sono il responsabile di questo progetto e ho ovviamente l'onore di avviare i lavori di questa giornata. E introduco immediatamente Mario Benatti, che è il sindaco del comune di Mirandola, per i saluti istituzionali e l'introduzione alla giornata.
Buongiorno a tutti e benvenuti a Mirandola. Mirandola sta rinascendo dopo il terremoto, provando ad investire prima di tutto nel futuro, provare a guardare oltre la tragedia che nel 2012 ha colpito questi territori, proprio pensando che la rinascita di queste terre parte sì dalla ricostruzione, ma anche dal progettare il proprio futuro e il futuro delle proprie comunità. Oggi a Mirandola, proprio in questo atteggiamento culturale che abbiamo cercato di concretizzare con tante scelte fatte in questi 2 ultimi anni, anche questo convegno di oggi importante su un fenomeno tra l'altro in continuo aumento, cioè la convivenza di tante persone con le malattie croniche. E questo viene sicuramente è possibile perché aumenta la speranza di vita, perché aumenta purtroppo la disabilità molto spesso delle persone e anche per altri motivi. Io credo che a questo fenomeno sempre più, come dicevo, largo e importante, bisogna rispondere con servizi che debbono caratterizzarsi sempre più dalla qualità e la professionalità delle persone che operano in questi servizi, dalla loro umanità, dalla loro sensibilità, ma anche dall'accessibilità universale di questi servizi, da un sistema socio-assistenziale sanitario in grado di evolvere con le richieste, con le necessità, con i cambiamenti in atto e naturalmente da una continua emissione di innovazione tecnologica. E quindi l'idea di investire in innovazione tecnologica proprio per rispondere a quelle esigenze che dicevamo prima. Io credo che una delle sfide che la sanità ha di fronte e che quindi dovrà affrontare questa sfida pensando anche a un approccio nuovo è sicuramente il tema della domiciliarità di questi servizi. E quindi con l'idea che le tecnologie che vengono introdotte per affrontare una sfida di questo tipo devono essere prima di tutto semplici, perché hanno bisogno di essere, come dire, trasportate, così miniaturizzate, per cui più piccole possibile, perché si dovrà sicuramente avere a che fare con macchine che possono stare nel bagagliaio della macchina o altrimenti di fianco al letto a casa, il controllo a distanza e quindi tutta una serie di tecnologie e di innovazioni che possano portare sicuramente ad affrontare questo tema in modo efficace. Quindi sanità e tecnologia al servizio, come dicevo prima, di una popolazione con esigenze e necessità nuove, ed è proprio per questo, per mettere in campo nuove sfide, nuove tecnologie, ricerche e così via, che in questo territorio, con la regione, con l'università e con tanti altri soggetti, si è costituito il polo tecnologico e che verrà inaugurato proprio il 29 di novembre e che mette assieme proprio sanità, impresa, ricerca universitaria e formazione per dare risposte sempre più moderne alle esigenze dei cittadini che soffrono delle malattie croniche. Ecco, questo convegno sicuramente darà stimoli per l'importanza, per le competenze rappresentate, per le esperienze rappresentate. Dicevo, questo convegno sicuramente darà stimoli e proposte interessanti e proprio per questo vi auguro buon lavoro e di nuovo benvenuti a Mirandola.
Passiamo ora la parola a Tommaso Rotella, che è assessore alle attività produttive del Comune di Modena. Prima di passare la parola, colgo l'occasione per ringraziare ovviamente tutte le istituzioni presenti, sia a livello locale che a livello regionale. Prego.
Io faccio solo il saluto anche in inglese, poi le due parole le dico in italiano, se c'è bisogno le traduco anche. I bring the greetings of the mayor of the city of Modena. I work with him, I'm an alderman and I'm appointed to the economic sector. Okay. Questa è la parte inglese del suo italiano. Io nelle letture notturne dei quotidiani purtroppo riesco a fare solo molto tardi. Questa notte mi sono imbattuto in un bell'articolo di Edoardo Segantini sul Corriere della Sera, nel quale spiegava che la famosa Silicon Valley, alla quale insomma, tutti miriamo fondamentalmente come obiettivo di sviluppo, e in verità ha una matrice notevole di investimento pubblico che deriva dagli sforzi che gli organi che presidiano lo sviluppo delle attività belliche hanno svolto, e in particolare della National Defense Research Committee. E questo mi ha fatto pensare proprio nell'avvicinamento a questo importante evento che oggi si svolge, che la sanità possa essere per noi il tema che è stato l'industria bellica negli Stati Uniti, cioè può essere quel tracciato di collaborazione tra le istituzioni pubbliche, la ricerca e il privato, che nasce da un'esigenza forte e molto condivisa, che è quella di dare un sostegno, un'assistenza alle persone che possono avere più difficoltà, che hanno problemi fisici, ma sul quale appunto si possono incrociare una componente forte di ricerca, di risposte a nuove domande. È evidente che l'invecchiamento ci pone dei temi nuovi, voi lo avete messo in grandissima evidenza nella brochure introduttiva del convegno. Noi siamo una società che invecchia e questo è un fattore positivo, insomma l'allungamento della vita è certamente un fattore positivo. Siamo una società che ripete uno schema che è già conosciuto. Il Giappone ha 122 milioni di abitanti e la maggior parte ha un'età significativa. Questo ha prodotto uno sviluppo di una società il cui PIL poggia in maniera preponderante sopra il 70% su attività di servizio. Quindi è evidente che noi su questo tema, su quello che voi oggi vi apprestate ad affrontare, ad approfondire, giochiamo alcune risposte fondamentali. Queste risposte fondamentali sono le emergenze dei nuovi bisogni, quindi l'aumento del numero delle persone che hanno bisogno di assistenza pone il tema forte dell'assistenza domiciliare che voi affronterete, ma pone anche un tema di grandissime opportunità che il privato e il pubblico possono insieme sviluppare, perché è proprio in risposta a queste nuove domande che può nascere nuova ricerca, che possono nascere nuovi prodotti e che quindi può nascere un ritorno alla vitalità economica. Io credo che questo territorio, che è un po' il nostro orgoglio, io lo dico da amministratore della città di Modena, ma la vicinanza, oltre che affettiva per note vicende, ma la vicinanza con quello che è in Mirandola, che è un nostro grande esempio di interpretazione di quel concetto di collaborazione tra le amministrazioni pubbliche e le entità private, sia davvero un modello che va sostenuto, e quindi io credo che con la collaborazione illuminata di Democenter, il nostro partner importante anche su Modena, possiamo insieme trovare una strada per dare delle risposte a chi ha necessità di risposte al sistema sanitario, ma anche delle risposte a chi ha bisogno di un rilancio economico del territorio. Io vi ringrazio e mi scuso, saluto.
Grazie. Passiamo la parola a Luciano Vecchi, che è assessore alle attività produttive della regione Emilia-Romagna, ricordando che Licia è in rappresentanza della nostra regione, e anche perché ha avuto una bella esperienza di 10 anni, se non ricordo male, come parlamentare europeo proprio nel gruppo Anziani. Prego.
Grazie. As everybody is trying to speak English, I do the same, even if I know that it's a sort of pidgin English, but this can be more or less understandable. I want to give you, of course, on behalf of the regional government, the warmest welcome. And I would like to say it in all your languages, but I just speak few. And underlining that this is for us a very important moment. Of course, what the president will continue in Italian, but what I want to say is that it's not just a formal thing that you have here, and not only because this is a very special place, because this was completely wrong, strongly destroyed 3 years ago by a terrible earthquake, and now, after 2.5 years, is already a live and working area. But also because what you are discussing here, bringing experiences, exchanging criteria, is something very important, because it takes two fundamental aspects in building up the future, which are, on one side, to have research, innovation, technological transfer, so in order to give our economy competitive, sustainable, able to face the challenges of the future. We know that everything we have done in the past, it's not useful in the future if we are not able to renew it in a very strong and concrete way. But at the same time, this is underlining another important aspect, that everything is concerning research, innovation, development. It should be something which is good for the people. It should be something which improves the living condition of the people. Because finally, the aim of what we are doing is not just getting more money or more jobs, which is of course very important things, but it's letting the people to live in a better way. E continuo in Italia. E questa sfida è qualcosa che è estremamente importante, cioè il fatto di riuscire a combinare sviluppo economico attraverso la ricerca e l'innovazione e il miglioramento delle condizioni di vita delle persone, soprattutto nelle aree come la nostra, che vivono allo stesso tempo alcuni elementi di sfida positiva, ma che sono molto difficili da affrontare in modo tradizionale, tenendo conto del fatto che le compatibilità economiche e sociali stanno cambiando. Questa è una regione tradizionalmente ricca, ma è una regione anziana dal punto di vista dell'età media. Abbiamo superato il 1.000.000 di persone che ha più di 65 anni e il 55% di queste persone non rientra nella categoria delle persone che godono di buona salute o non hanno fragilità. Quindi il 55% rientra nelle altre categorie, problemi di salute a volte estrema o problemi di fragilità sociale che può diventare anche, può avere aspetti anche patologici. E allora il tema che affrontate in questo convegno, che non è un convegno formale, cioè come sollecitare lo scambio di esperienze, la ricerca scientifica e tecnologica e il trasferimento tecnologico, quindi la capacità di influire sia sul mondo dell'impresa che sul mondo dei servizi pubblici o privati che siano, è una delle chiavi di volta appunto per dare risposte in grado non soltanto di soddisfare le esigenze dei singoli, ma in grado di garantire qualità e coesione sociale. Ed è per questo che davvero seguiremo con attenzione i vostri lavori, and this is why we think that the dialogue and the cooperation you will develop in these very important days should be continued in the future, because this is an important part of what we have to do in the next years. Thank you very much.
Chiedo ora a Giuliana Gavioli di venire qui di fianco a me per fare la presentazione. Giuliana Gavioli è il referente del settore medicale della Fondazione Democenter, responsabile del gruppo biomedicale Confindustria, presidente dell'ITS biomedicale e anche referente di una delle importanti aziende del nostro territorio. Prego.
Grazie. So, good morning, ladies and gentlemen. I use this probably it's too high for me. Okay. So it's a pleasure for me also to welcome you to this conference on aging wealth on behalf of Democenter. As you heard, I am also part of Democenter. It's my task today to give you a short explanation of the biomedical district here in Mirandola. And I have some slides to show you. This one. So the biomedical industry, the biomedical district is an agglomerate of industries focused on the production and development of medical devices, both in form of actives, so we call them equipment, and non-active device, and we call them usually disposables. Starting the manufacturing activities in the 70s, the district developed hugely in the 80s and 90s with a very positive economic trend, since in this area were attracted several multinational companies that purchased the biggest company in the area. This is the biomedical district industry from the point of view of multinational company. As you can imagine, the multinational company developed, or during this acquisition was developed a very important substrate of a network of suppliers in the area. The founder of the first company in 1964, the first company was Dr. Mario Veronesi. He's the founder and is the founder of the biomedical district here in Mirandola. He was invited to the conference today. He cannot come due to some health problems, and he asked me to give you his greetings. And he will participate to the next conference for sure. So the first company was an Italian company founded by Dr. Veronesi and was sold to the first international company, Dasco. And from that moment, during the years, you can see that we had a very strong development of industry located here and strong acquisition also in the last year of companies from the biggest multinational companies. These are the different medical therapeutical fields in the district. So you see that, as I said to you, the companies are devoted to development and production of medical devices. And in these therapeutical fields, so hemodialysis, infusion, transfusion, and autotransfusion, earth surgery, enteral and parenteral nutrition, continuous renal depressant therapies, anesthesia, gynecology, apheresis, and plasma apheresis. So most of these, especially also at European level, are therapies that are applied to the patient also at home, so home care, are part of home care. And this is a very important aspect that we will treat during the conference in these 2 days. Some information about the specialization and the company size. As I said, we have multinational companies, we have also middle companies, and we have a strong network of suppliers. Suppliers which are in many cases high developed supplier which are able to supply and provide finished product but also complex components. So you see that the specialization is in production and development of finished product and complex components in the field of disposable, 80%, but also in finished product in biomedical equipment. These, let's say, you see that we have in the province of Modena 92 companies. You will see also the next slide. And the turnover of this is more than 1 billion euro. Here I give to you the information, let's say, of Italian versus foreign companies. So we have 91% of Italian company, but if you look at the turnover, you can see that 41% is Italian turnover, and the remaining part, 59%, is for foreign companies. The data that I have are published data that I presented here, so in some cases should be updated because, let's say, are not updated to this year. In any case, the number of companies is data that is, was reported published in 2009. In the total province of Modena, we have 92 companies that are working in the biomedical fields. 62 of these are in the north area of the province of Modena. The north area of the province of Modena is exactly this location where we are, where we have Mirandola, but also Medolla, other little towns which are linked to this area north part of the province of Modena. The characterization of this area north, so Mirandola and the other town located here, is let's say in micro, little, middle-sized companies. Only in Mirandola, so only in the area north, sorry, not only Mirandola, but Mirandola and Medolla and Cavezzo, we have big companies, 5.8%. This is a very important information because it's due to this presence that the district was really strongly developed in the last years. The operator of the district, I have a data published in 2009 that inform us that the operators are 3,500. In reality, today, in 2014, we know that we have 4,500 employees in this area. And for what concerns the turnover, I already said that let's say the data that we have in 2009 of turnover is in reality increased, and in 2013 we had more than 1 billion of turnover from this district. These are, let's say, a few slides, are numbers. I would like to point out to your attention of the numbers which are related to the year 2012, because this is very important. You know, and you said you know that we had two earthquakes in May 2012. Despite this earthquake, we were able to slightly increase the production of this area, so manufacturing devoted plus 0.2%, but this is a very important information for us. And when we talk about the export, you can see that the export of the first 6 months of the 2014 versus the first 6 months of 2013 had an increase of 0.57%. So this is a very important information during this economic crisis and after the earthquake that confirm that the biomedical district of Mirandola is a biomedical district that up to now is able to live in this very difficult economical moment. I have finished my presentation, and now I give the floor to Professor Aldo Tomasi, who will give you some information about the scientific and technological park of Mirandola. Sorry, I've done your work.
Colgo solo l'occasione per, visto che abbiamo appena avuto modo di guardare i numeri delle imprese di questo territorio, colgo l'occasione per intanto ringraziare tutti gli imprenditori presenti qui in sala e i rappresentanti delle imprese del nostro territorio presenti qua in sala. e condividere che siamo convinti che questa conferenza, in particolare i lavori di oggi e domani, saranno molto utili per far emergere nuove idee, per far partire nuovi progetti di ricerca industriale e di innovazione di prodotto, e quindi sono convinto che saranno molto utili per avere in futuro opportunità di realizzare nuovi prodotti e nuovi servizi. E ovviamente la possibilità di sviluppare questi progetti in collaborazione con l'università, in particolare con l'Università di Modena, pensiamo sia un aspetto fondamentale. E quindi ripassiamo nuovamente la parola al professor Aldo Tommasi, che è stato già rettore dell'Università di Modena e che in qualità di responsabile scientifico del Tecnopolo di Modena non solo farà i saluti in questa prima sessione, ma coordinerà in qualità di moderatore anche le sessioni di lavoro di questa conferenza. Ringrazio tutti e colgo di nuovo l'occasione per augurare buon lavoro. Grazie.
Buongiorno a tutti e benvenuti. But from now on, forget Italian, right? And so we start all the session in English, and I'll be your guest for the continued for the day. And so I'll be here. You will learn to bear with me for a while. Anyway, as Joana introduced me, I've been the rector of the University of Modena and Reggio Emilia till last year, and now today, in fact, I open and I'd like to bring the salute of the rector, for which I'm delegate here today, and so a few words as delegate of rector to the guest. The University of Modena is more than 700 years old. So it's a little bit of an institution in this part of Italy, and definitely is the task of this university, differently I would say from other Italian universities, is to look forward to collaborate with a local environment and industry. This task is not so easy in this country. Nonetheless, I mean, we try to develop continuously, and particularly with the collaboration. It's not the case that today we are here together with Democenter. So, what I want to explain here, that the university tried to get a direct link to the local environment and to the local companies and industry through Democenter, and through obviously also direct contact of professors and contributing to research and advancement. So this project, and in fact I'm shifting on to my task of today, the project of building a technopole, which means a center for advancement and research and development, obviously, was born 2 years ago, exactly a few days after the earthquake. So my question was at the time, how can we help? How could the university help? And obviously the same question was also made by the region, the regional government, and by the local industry, by the local people here, and the Comune, and obviously the mayor here with us. And so all together we start discussion, and with the help of the region particularly, and of the social European funding, we were able to start off a structure which I think should be behind. May I have the slides of the structure okay, here it is. It is actually very near to here. It is a few hundred meters from here. It is laboratories, actually 3 different laboratories: toxicology, molecular biology, and sensory, so engineering sensory of sensors, which have the strong intention to co-work continuously to solve the problem of the industry, and obviously to bring forward new research. Within this frame, the meeting of today was born exactly with this task. Let's try to finalize on some very different issues, what we could do, and what international guests and European obviously guests in the frame of the Horizon 2020 particularly can do. And this is the reason why the Democenter a few months ago started to work on this project. Today we are here, and I think the long list of distinguished speakers demonstrate that I think we have been successful. So let's try to work together today and tomorrow, and really to finish off with giving the good basis for good collaboration and collaborative research, starting here, but all over Europe, in this frame of funding application and collaboration within the European frame. So having said that, and knowing that we are usually Latin people, I mean, we are not only the only Latin presence here today, now take it easy, but I'll be your chairman now from now on, and I'm rather tough. I'm from Habsburg origin, and so I will try to keep on time and try to give enough time for every one of you, of the speakers, to explain what they want to do, and particularly have ample discussion. So I may finish this long introduction, and I think that in a very short time we can start with the first speaker of today. Nonetheless, let me call the first speaker for today. Is Joana Mora Amengual. As you see, there is a short introduction for each of the speakers, so you are not, I'm happy if I do not introduce with length, but I leave people to read your CV. And please, you.
Okay, thank you so much for inviting me. My name is Joana Mora, as Tomasi said. My background is, well, I come from the Basque Country, and I was working for 3 years and a half in the Department of Health, and we are very close with Rafa Bengoa in the transforming of the health system in the Basque Country. And nowadays I am working in KRONIKGUNE, which is a center of research in chronic diseases, but not in basic research. We are focused on implementation and innovation and organizational innovation. And so I will try to explain a little bit more about how to make sustainable model for healthcare and social systems. But firstly, I would like to make a short introduction about, well, I think so this picture is well known for all of you. This is the demographic pyramid, and during the last 60 years, this picture, the shape have changed considerably. Nowadays, we can say that thanks to the advance in medicines, among others, the life expectancy has increased very high. Nowadays, the people live 30 years more than in the 60s. And obviously, it has a great impact in terms of the chronic disease. In the 60s, well, we know that the age has a great relationship with chronic diseases, more age, more chronic diseases. And in the 60s, people live around 50 years old, and the prevalence and incidence of chronic disease was very low. But nowadays, the situation is completely different. We have around 30% of patients with chronic disease in our regions, and in terms of impact in healthcare expenditure, has a very high impact. nowadays the healthcare expenditure has increased 5 times during the last 60 years. And obviously we have to manage with this situation. The mix of diseases has changed and has a very high impact in our health care expenditure. So if we focus indeed, or if we analyze this healthcare expenditure, we can see that the 70% of the healthcare cost is related to chronic patients. And if we analyze indeed admissions, so sorry because it's in Spanish, but ingresos is admissions, you can see that the percentage increased until 84%. And we have a problem in this point, and we have to try the ways of solving this. But when we are talking about transforming or to make sustainable models for health and social care, we are not talking only about to introduce some kind of ICT tool or some kind of pathway. We are talking about another thing. We are talking about transform healthcare systems and social systems. Our clinicians have to manage every day more than 6,000 drugs, 30 millions of clinical contents, a lot of surgical procedures, and it is a hard work. But there are around this work, there are a lot of stakeholders like policymakers, funding and commissioners, ICT providers, healthcare and social providers, workforce, and organizational models, that all of them are working around this topic. So, as I said before, we are talking about transforming healthcare systems and social health systems, not how to make sustainable one process or whatever. But it's not easy, because we are talking about transforming very complex systems, but there are some experiences that show that it could be possible. And here we can see several of them. For example, in United for Health, or in United States, there are accountable care organizations. In Scotland, coordinated partnerships. In England, integrated care systems. In Northern Ireland, integrated care groups. And in the last country, integrated care organization. And also, for sure, there are more experience around the world that it would be follow the same line. And in terms of evidence, we can see only one example, that in the last years, there were the number of hospital admissions has been reduced considerably. Also, readmissions and emergency admissions. But in terms of cost, it has the same impact. The cost evolution has decreased also. But for me, the most interesting thing is that there is a redistribution between hospital or secondary cost and primary care cost. The primary care has more, is slightly, but it's significant that every day the primary care has more presence in our healthcare system, and that means that step by step we are a replacement of the take care people more at home in terms of hospital. So, which is the change in the delivery care that are conducting these healthcare systems? So most of them are centered in chronic patients. They think that proactive model design to cure, care and prevent is the correct way. They believe that the patient has to have an active role in managing of health of his illnesses. The most important thing is that we have to ensure the continuity of care between healthcare, secondary, primary care and social services. Another thing is that the delivery of care will be done in the most suitable and efficient place. And we need a reform in terms of payment. Until now, we are paying most of our regions by activity, and we need to start to pay per health outcomes. So I would like to summarize, well, I think 3 main principles in order to transform a system with high complexity that we are talking about in this moment. We need to move several bullets or drivers of change at the same time, use distributed leadership, and implement a change management strategy. So nowadays, so let's move on in the first point and how we can introduce several. When I'm talking about bullets, what does it mean? The first point is to need to introduce capacity in our healthcare systems, because most of our healthcare system and social services born in the 50s, 60s, and the prevalence of acute disease were higher than the chronic diseases, but we need to change, and there are things that nowadays our systems don't have. Another important thing is that we need to promote the local innovation and knowledge management. The third one is change the way of payment and incentive and to establish specific objectives. And the last one is, well, pivotal drivers or transversal drivers that are not specific things, but general things that are very important. So in terms of capacity building, when I say how to generate capacity in our organizations, what does it mean? We need to introduce several tools that in our regions or in our healthcare systems doesn't exist, or some of them yes, but perhaps others no. But all of these kind of things are called integrators that help to improve the coordination or the empowerment of patients or whatever, or introduce some kind of proactivity in our healthcare systems. And these kind of tools are risk certification, ICT systems that will allow to share information and monitor patients and to make follow-ups, clinical reminders or whatever. New nursing roles like case management, to develop new skills and competencies in our workforce in order to work together in a collaborative way and like a team, like a real team. Introduce some kind of Telecare, telemonitoring in order to monitor the patient when the patient is at home, because most of the time these kind of patients are at home, not in the healthcare systems. And then finally, but I think is one of the most important, is to change the way of deliver our care, and the patient is not a passive patient. We need patients that they will know their own illnesses and that at the end they will be capable to manage their own illnesses. In terms of local innovation and knowledge management, obviously, as I said before, our healthcare system and social services are very complex. There are macro level, meso and micro level, and from the macro level, it's impossible to provide all the solution for this kind of systems, huge systems, and most of the times the answers are at local level in the front line. So we need to promote local innovation and then generate evidence. That not means promote innovation, but not evaluate and what happens after this. Also, we need to generate evidence and to spread up and deploy these good practices. But also we need some kind of facilitator that provides methodological support, staff, and assessment at local level. So, in terms of payment, well, the payment system incentive and objectives that are be aligned behind the purpose of integrated care. And nowadays, most of the type of payments are based in activity, and the effect that it provokes is not that we are looking for. They provoke a fragmentation, that organizations work only in silos, not in a coordinated way, and the impact in terms of health outcome is not so good. So we need to move forward to another type of payment statement that promote coordination, improve health outcomes, and avoid gaps and duplicities among the organizations of the healthcare providers and social providers. So in terms of pivotal drivers for transforming the delivery of care, obviously we need leaders of vision, clear visions. The transformative power comes from partnership and teamwork, but all these teamwork and partnership have to be aligned with the idea of integrated healthcare and public care and social care, embrace integration and coordination of care across organizational silos and patient-centered. Assessment, evaluation, and continuous improvement is another key point, and all of them have to try to be aligned with the triple aim. That means population health, health outcomes, and efficiency. So my last slide is this picture that tries to summarize all that I mentioned before. This picture tries to represent the distributed leadership. That means some of the things can develop by the top, but other things you have to promote at local level and have to be developed in the top at local level. In the center of this picture, there are all the things that we are talking about before, tools and integrators that generate capacity building in the organization, but all of them are aligned with the triple aim: improve medicine, population health, and efficiency. So thanks so much.
Thank you so much for both clear exposition and keeping the time. So, obviously we do have a space for any question which might arise. Otherwise, as you know, the speaker will be here and it might be contacted all over the meeting. Is there any urgent question arising now? Please.
My name is Stuart Anderson. I'm coming from Greece. I'm aware of the very good work you've been doing in Basque Country from Esteban. I would like to ask you to be a little more specific on the reimbursement scheme. You mentioned about bank payment. If you can be more specific.
What does it mean? Yes, the bundle payment is
what you are doing.
What we are doing.
Yes.
Wow. In a short presentation, it's quite difficult. But the idea is that, well, in our system in the Basque Country, we are organized. Our healthcare provider, well, 96% of our healthcare provider is public. Is only one. Is Osakidetza, and it has several hospitals and primary care centers around all the territory. But we have organized our providers in terms of population. This population has their own primary care centers and one acute hospital or subacute hospital as a reference. And the bundle payment in our region consists in one to share part of the budget. And there are established common objectives in terms of some kind of interventions defined by how to improve the delivery of care of frail patients and the most common chronic diseases, heart failure, COPD, and diabetes. And this budget is shared between other organizations that provide the delivery of care to this patient. And if at the end they don't achieve the objectives established in the evaluation framework, the Department of Health retains some kind of money, not only primary, both primary and specialty care. The idea is to share budget between all the organizations that they are taking care of a pool of patients in terms of objective.
Thank you. How much did you say?
How much?
No.
Well, obviously.
This is my question. Your own budget.
So, I was showing you before, this is one example but this is the slide that you can see the saving that achieved for only one microsystem or in the basic care organization.
I think our Director Generals might be very interested. Which are here. Anyway, no other question arises, then thank you very much.
And of course, I'm going to talk about drivers first. And of course, you've seen this before, yeah, and you'll probably see it many times. But I wanted to make one point, which is, I think the critical thing is not the shape, it's the dependency ratio. Yeah? And the dependency ratio is really driven by two things. One is long-term conditions, as Joana pointed out. The other is employment policy, because we force people to retire too early, and we don't give young people work. And if those two things were solved, we would not have an aging crisis. Yeah, we would still have long-term conditions, but early retirement and youth unemployment, I think, are really the critical things that we want to change. Here's an interesting, these are mostly data. This is a picture of end-of-life costs. This is last 12 months of life costs. And if you look, once you get over 70, then really what starts to happen is that the social care costs start to rise very significantly and the healthcare costs start to fall. So when we look at old people we have just as much. And if you look at crosses round about 90, yeah, but still at 70, we begin to lose the tracking of the overall cost around the medical cost, because actually what we need to do is we need to put in more and more social support. So the two things have to work together, and this drives integration. So I think this is very important. The next thing is inequality. And if you look on the left, this is social class and life expectancy. And the green line is female professional employment. The red line is female routine employment. The black line is male professional employment, and the blue line is male routine employment in terms of life expectancy at age 65. Yeah? So we have huge gaps in the UK. The other thing we have is we have a growth in our systems of unhealthy life years, and that's what the thing on the right-hand side tells us. Because if you look, you'll see that we're pushing up life expectancy. There's quite a nice slope on those blue and red graphs on the right-hand side. But if you look at healthy life expectancy, it's stubbornly growing at a slower rate. So our health systems at the moment are building up costs. Our populations have more and more unhealthy life years built in, and those unhealthy life years manifest later, and they manifest in terms of cost to the system. I think this is inequality in healthy life expectancy in the UK. This is for males on the left and females on the right. And if you look in terms of the bottom 10%, in terms of poverty to the top 10%, the difference is 20 years in healthy life expectancy, which I think is a scandal. And it's a major driver in terms of Scottish policy. Multimorbidity, it happens 10 years earlier for poor people than rich people. This is the graph for Scotland. Yeah? So if you look, the red line is when you have 2 or more conditions in terms of the lowest decile, in terms of the deprivation index, and the bottom line is the top decile in terms of the deprivation index. So it's the least deprived people get multimorbid things much later than the poorer people. So long-term conditions and comorbidity, 25% of UK populations have long-term conditions, 20% of people with long-term conditions have 3 or more comorbid conditions, and 30% of over 80s will have some form of cognitive impairment. So these are all issues in terms of this. In terms of cost, Joana mentioned this, it's 18% of UK health budget, it's 42% of Scotland's overall budget, it's 8% of GDP. If you look at the US, it's 18% of GDP in the US. So we can grow it, yeah, but the question is, will our economies sustain it? This is the question. This is the other thing, I think, which is extremely important, which is just exactly what the unreckoned economic cost of care in our society is. Because this is the graph of the value of informal care in the UK. Now, this is from Office of National Statistics. The estimate is £70 billion per year. The estimate by Carers UK is 120 billion a year. The value in Scotland is roughly 10 billion a year, which is roughly the same as the health budget. So we're talking about basically completely neglecting something which is of economic value which is roughly the same as the budget of the systems that we're looking at. And those people are relatively unsupported. So I think there's a really critical thing about doing something about informal care and doing something about carers, because it has a huge economic impact. So our drivers, ageing population is less important. The real critical thing, I think, is dependency, growing unhealthy life years, long-term conditions, comorbidity, cost, health inequality, and the huge informal contribution that we haven't really done anything about. I think the important thing here, and maybe the authorities have gone now, but is I think the critical thing is in 2011 in Scotland we had a thing report called the Christie Commission. And I'm just going to talk a little bit about the structure here. So the Christie priorities are what are the priorities for the delivery of public services in Scotland. Then there's a thing about delivering public services, and then there are three pieces of legislation coming through that have various different effects. But so here it is. So this is the top line. Recognising that effective services must be designed with and for people and communities, not delivered top-down for administrative convenience. So that's the top line in terms of the policy for public sector delivery in Scotland. Digital first and joint working. Integration will ensure that health and social care provision across Scotland is joined up and seamless, especially for people with long-term condition and disabilities. Yeah. This bill went through. This is the bill that compels health and social care in Scotland to work together. So it's a legal entity. This was passed in February this year. And there are future things coming through. So the next thing is community empowerment, which is actually going to mean that the state divests assets to the community, so things like buildings, land, facilities, and so on. And then also there's a procurement bill coming through which mandates that procurement should aim to be sustainable and deliver social and environmental benefits, as well as supporting innovation and promoting public procurement processes that are transparent, streamlined, standardised, proportionate. So they're pushing on changing the way that we buy things. These are the Christie Commission priorities. I don't intend to talk about this because I've got a lot of slides. So the question is vision, and here I'll talk a little bit about, we have this thing called Joint Improvement Team, and if you like, the three-step improvement framework for Scotland's public services are change the world, create the conditions, and make the improvements. So the macro system, meso system, micro system, and that drives the way that we change things. These are the priorities, so there are things like place, home and community, integration, partnership and collaboration, improving practice and performance, and so on. So the priorities are all around how do we deliver for the community. The chronic care model, at the moment, this is a chronic care model that drove the redesign to some extent, and it's essentially a supported self-management model. But as you'll see when we come later, we want to step beyond that next, so to go to the next step. So here's the reshaping care for older people, and it's really, this is the structure, and the idea is to shift the balance of care and resources back into the community. There's a £300 million change fund between 2011 and 2015, and the thing is to build partnerships to achieve that move. I'm going to talk a little bit about the redesign. So the redesign, there's lots of detail in the redesign, but if you look, we looked at preventative and anticipatory care, proactive care and support at home, effective care at times of transition and hospital care. I'm going to talk about one thing, which is about the development of anticipatory care plans, and say a little bit about that. So one of the things in terms of anticipatory care plans is looking at readmission and admission. So we use SPARA, which is a risk analysis tool, so it's looking at the data, doing stratification, identify the key groups, so looking, seeing 40 to 60% chance they need an anticipatory care plan. First choice. Second choice is the next 20% down from that in terms of risk, because the higher guys are already likely to have that. And I'll talk a little bit about outcomes at the end. And these are the sorts of things that the anticipatory care interventions that are built into the anticipatory care plans. So there are lots of other interventions in intermediate care, falls and fracture prevention, dementia improvement program, and support for care. So there's a whole slew of things, all of which support the development of that transformational approach to the way that care and health is delivered. And of course, there's lots of detailed work, lots of looking at data, and lots of using the data to change the way the community actually operates in terms of its experience of health and care. I'll say something very briefly about infrastructure. The key information summary was developed kind of bottom-up to support anticipatory care plans. It stores the basic data that's needed by the people who are responsible, who are most responsible for delivering those elements. So the key information summary is something which, if you like, is built by need, not by a top-down driver. I'm not going to say anything more about this. This is a co-production architecture that we're looking at. But what it has here is it's got an interesting architecture, because if you look at the two big infrastructure components, the NHS Information Service, NHS Inform, and this thing called ALICE. And the thing about ALICE is it's a hyper-local, prosumer-based information system, which actually produces local information system produced by local people for local people. And it does various other things as well, but that's the sort of thing that it does. The challenge, I think, is moving from supportive self-management to co-production. How do we co-produce? And there's one big scale experiment going on in Scotland that should touch 55,000 people, and that's living it up. So, and here I'm just going to quickly run through these slides just to point out the kind of effort that's going in and the kind of effort that you need on the ground in terms of actually getting something like this to work. So this is the sequence of events towards getting Living It Up built. And the idea is Living It Up is something which supports co-production of support in the community, so with health, with social care, and with the community. And if you look, these are all, so looking at and doing engagement, looking at community engagement, co-design workshops, co-design prototyping, user testing, more user testing and engagement, and finally building Living It Up. And the aims are finding out what's important, so it's actually about going down, and here we use people from Glasgow School of Art. They're design innovation people, and they work very hard with the community in order to build a community around these things. They ran numerous events. They ran lots of pop-up engagement sessions in places like shopping centres and so on, and the number of people, 1,500 people involved, interviews and focus groups, workshops and so on. So there's lots and lots and lots of community engagement, dealing with people like the Alliance for Health and Social Care and Carers Scotland. Around about 2,000 people, more than 100 events across 5 regions. Yeah, so I can skip this one. So these are things like co-design workshops, and these co-design workshops got everybody together. So the developers were there who actually developed the pieces of software, who did the architecturing. Social care and health people were there, people representing carers, people representing patients and users. If you look, this is the wordle of the branding stuff that they did, and of course the key thing in the middle is trusted, accessible, reliable, and information. You know, so it's an interesting little structure there. The design principles: it should be welcoming, it should build community, it should be innovative, person-centered, personalised, and adaptive. And adaptive, if you like, by the needs of the community. This is just the structure in terms of we need to know about healthcare on the individual, we need to know about the individual needs in terms of what they're prepared to give into the community, and also what happens in terms of service providers, in terms of what can be provided with a marketplace for people actually accessing skills and services within the community. And then filtered by the profile, you get access to a whole bunch of local services. So this is the build-up. So the structure is to engage people and to find out what they want and to find out what their capacities are, and to combine them usefully and artfully in order to produce the required effect. Impact of the overall redesign. So this is not so much about the co-production move at the moment, but if you look, this is daily beds used by emergency admission. So this is some of the output of the SPARA tool. So if you look, the predicted numbers are here, and the actual numbers are declining quite significantly, so there's around 1,000 difference there. If you look at long-term stay in terms of care homes, that's people being supported at home, predominantly by Telecare and other means, then again there's quite a significant difference, probably around 1,000 people involved there. Emergency day beds, again, a decline over the long term of the introduction of this scheme. So there's quite a strong impact from this. So the conclusions: strong legislative commitment to change the locus of health and care, detailed work informed by data to target areas of greatest benefit in terms of cost and quality of care. Implementation needs to engage and enable staff to change. And the next big step is from supported self-management to co-production. And there we are. That's the jolly co-production bus taking us to improved outcomes, higher quality, and the sun shining, even in Scotland.
Thank you very much, Stuart. This was really packed talk, really full of information, and probably needed much more time. But again, you were able, absolutely. So, if there is anyone who would like to put any other questions as before, okay, good. Go ahead.
Is the Living It Up campaign? Is the Living It Up campaign the actual? Is that what caused the impact and the decrease in the use of the services?
No. I mean, the things that you saw were actually on the main care redesign. So that was really introducing supported self-care. Yeah.
But you had the legislation in 2014, so you were doing some of this work before the divestiture of the funds down to the regional level.
Yes, because we had the joint improvement team and we had the Christie Commission report. Christie Commission, I think, started working in 2007.
All right.
It reported in 2011. 2014 is the beginning of the legislative program. I think in 2 years' time, the Community Empowerment Bill will come through where we can look to move facilities to actually be self-managed in the community.
Okay, all right.
So it's a...
I thought Living It Up had caused all those things. I went, what?
No. Living It Up is if you like, the big experiment to see where we can go next.
Right.
Because I think fundamentally you need to work out how to use the resources effectively.
Right.
And that's the community resources.
Right. They're using that in the Smart Care project.
Yeah.
And I'll talk a little bit about that. So thank you.
But, sorry.
Thank you again, Stuart. May I introduce the next speaker? Marta Ribeiro from IESE Business School, University of Navarra. So business people are bringing their help to medical doctor. I think this will be more and more the case. And we need more ICT and more engineering and so on. Yes, absolutely. Please.
Hello everyone, thank you. I would like to start by thanking the organizing committee to invite me to present here. Actually, I'm here on behalf of a project that we are participating in, which is Offer Project. And within this project, we've been looking into business models for mobile solutions, apps for independent living of elderly people. So let me start by talking you a little bit about the project. It's in Alfred we want to give a mobile personalized letter, an app or a group of apps for helping older people to living independently for longer. It has 4 core elements. It should be totally voice control. It has a social inclusion function with an events manager to suggest to the user some events that he might be interested in attending. It has also a healthcare component linked to wearable sensors, so we can track some of the main healthcare data, and also a serious gaming for not only physical but also cognitive impairment prevention. And the results will be tested at 3 pilot sites with more than 100 users from France, Netherlands, and Germany.
This project started 1 year ago. It has a total duration of 3 years, and it has a very interesting mix of partners. We have SMEs, which are essentially looking into the technological side of it. We have also 2 universities, Charité with the gender and technology unit, Darmstadt looking into serious gaming. The Textile Association is developing wearable sensors to be associated with the healthcare component. We have 2 user associations, so we are sure that we are close to the end user, and we already perform focus groups, and we know the user requirements they need, and we will be using also these associations to implement and to pilot the final product. And we have a business school, which is IESE Business School, where I'm from, and we are essentially looking into the market, the applicability, the intellectual property rights plan and exploitation plan, and making it align with standards, policy, and ethics. So by the end of the project, we have something that is actually ready with a sustainable business plan, ready to be implemented and profitable along the way, even after the end of the project. So when we start looking into this, we start looking into how many ongoing projects we have, especially European projects. There are so many projects at European level. Then if we look into one of the different countries, we have so many things happening. But despite that, there are very few solutions into the market. And we realize that that's essential because it's not, the benefits are out there, right? We all know that mHealth promises a lot of benefits in healthcare management and health and in provision of care, health and social care, but it's not very clear how to capture this value. And this is what I'm here to talk to you about, to show you what we've been looking into, different healthcare challenges, some of them we've been listening until now, the mHealth apps market, how the different stakeholders are positioning into the market, and then focus a little bit more on revenue models, distribution channels, and all of these to understand how to position Alfred in the market. And I'll finalize my presentation with what is our strategy for Alfred. So we've been listening a lot about the challenges. We know that we are getting old with multi-morbidity conditions, but we also know the healthcare system is a very complex system, and here is just my attempt of representing a bit all of this complexity. We know that we are moving towards a patient-centric solution. We also want to put the patient in charge of his own health and changing from a disease management towards a health prevention status. And so we know that mHealth holds promises in putting the older patient in contact with some of the services. In the first layer, you can see the main services that are provided to older people. In the second layer, you can see some other services, but also some important stakeholders that are involved in the process. Though we have something that is also very important, which are the financial flows, and mHealth is not totally solving this, and this is something that we need to look into. Regarding mHealth market size, the provisions are great. We are expected to grow 7 times between now and 2017, but there's a huge gap between also now and 2017. And we also know that in the future, most of the profit is expected to come from additional services. So not by downloading apps, not by advertising, like many people have been thinking until now, but essentially by additional features and additional services. Regarding mHealth apps categories, as you probably know, it's essentially fitness and wellness, alongside with a bit of medical reference. This is targeted for the healthcare professionals. But Alfred is actually on top of serious gaming, focusing on remote consultancy, monitoring, compliance, and this is a rather smaller bit of the market right now, but it's expected also to grow a lot in the future. We look into the stakeholders, also try to understand if we are putting some apps into the market, what do we need to consider, what are the key partnerships, to whom should we go and try to establish this kind of collaborations. And these are the main stakeholders. We have telcos that obviously know a lot about designing network. We have healthcare providers that are the essentially point of contact. And they are also very important in fostering the adoption of mHealth, which is a problem right now. There are some studies, one developed by us at IESE, that show that actually medical doctors are less willing to adopt mHealth than the doctors are. So we have a problem regarding patients, but also regarding the doctors. The payers also, despite being public or private, they see a lot of advantages here in improving healthcare performance, providing better service, paying less. And then we have the medtechs who know a lot about hardware but should also get into the software. And finally the biopharmas that have been like ruling the world of healthcare in a way until right now. And they are not very sure on how can they have their bite there. Some of the big pharmas are already putting an app as a part of a service that they provide with a drug to increase compliance and adherence to treatment. So what we saw is that there are different stakeholders involved, they all have their different knowledge, but it's very hard that only one of them can really develop everything that is needed. So it's very clear that building partnership and collaboration is an important aspect here. So as a wrapping up, there are opportunities. The smartphones are the #1 connected device. There are forecasts saying that in 5 years from now, more than 90% of the world population will have a smartphone in their hands, so they'll be able to connect with anything they need to. They have a high penetration rate among medical doctors. The technology is in many cases ready. This is what we've seen, because in mHealth there are a lot of things ready, but they are just not in the market yet. Or if they are, they have not been successful. It's a way of reducing healthcare costs, to putting the patients in charge of their own health, increasing compliance and adherence to treatment, and overall improving communication not only between the patient and the medical doctor, but between the patient and the carer, the patient and the community, the patient and the family members, right? On the other hand, we have the high complexity of the healthcare service organization in Europe. In this project, we have Spain, we have Netherlands, Germany, among other countries, and when we start looking just how healthcare is organized in each country, it was so complicated. So this is something that we also need to consider when we want to provide mobile apps and we want to define a business plan that fits all of the different countries and regions within the countries. The market is still quite immature and fragmented. I mean, opportunities are out there, but nobody's really making a big use of them. We have different type of users, and essentially we have a reluctance to pay. It's still not very clear how the value can be captured. And this is the reason why we've been looking into the business model. So we decided to use business model canvas, as you probably know this. It has 9 main building blocks, and we've realized that in mHealth, the main problem is actually how to capture the value. And the revenue streams pretty much depend on one side on key partnerships, on the other on the customer relationships, and also on distribution channels. And now I'll be showing you the 3 main revenue models that we found that have been used for mobile apps for well-being, not for older people, because this is barely inexistent, and also giving you some examples of this. So we have the free or low-cost model. Normally the app is given for free, or a part of it is given for free, and you monetize it through alternative resources. This can be advertisement, this can be selling your data to another company. We also have the premium model for services that prove to be really better than traditional healthcare. And normally people have to pay for this, so it's very useful when you have a chronic condition and you really need to be followed up all the time. And it brings you an advantage to just do it by remotely rather than going to the hospital every time you have an incident or you need the help from your doctor. Also, this implies as a minus point that we need a mindset change. We need to educate patients, payers, and also medical doctors on the advantages, and we need to show them the advantages of the mHealth so they are more willing to pay. And finally, we have the outcome-based model. these one-time revenues to measure patient outcomes and cost savings. And for this one, you really need a lot of data and a lot of good analysis of data. So you clearly show the advantages of it, and then you can align what you pay with the advantages that you get. As an example of free or low cost model, we have the app Patients Like Me. It's a place where the user can track their health status regarding many different diseases. They can learn about disease. They can also share and connect with other patients like them, because this is one of the main things that patients sometimes say. I mean, my family, they are great to me, but they don't completely understand my situation because they don't suffer from fortunately they are not suffering from the disease that I'm suffering. It also allows them to do a real-time search platform and see what the others feel. This is for free. On the other side, the info is totally anonymized and is sold to big pharmas or other type of healthcare institutions. The premium model, as a premium model, I'm showing here the Blue Star. This is the world's first mobile prescription therapy. It's FDA approved, and it's being used in the United States for diabetes type 2, and it's reimbursed in the same way as a drug. And actually, it's part of the main insurance packs of many 500 Fortune companies in the United States. So on one side, it helps the patient because help him tracking his own status. On the other side, it's a collector of info. So when you go to see your doctor, you can really see how have you been performing in the last month or in the last 2 months. The final one, the outcome-based model, here we have the Health Buddy from Bosch, and this is also an interesting thing to see. What are the so many different companies stepping in. So Health Buddy is from Bosch, which is typically a medical device company, among many other things. So these help patients and providers in managing their chronic conditions. They provide this small device that you can see here to the patients, and they adapt it to the condition that the patient has. And then every day they keep asking you, how do you feel? Have you been feeling these kind of things? If yes, then they ask them another question. So they set some type of alerts. If it's really a very urgent thing, it connects directly to the healthcare provider. If not, it just says, well, you try to do this, and tomorrow I'm asking you again. And then if we see that in 2-3 days you are not performing well, then you need to see your doctor. An important point of mHealth solutions are distribution channels, right? Because there are so many things right now in the market that one really needs to think through how am I going to distribute my product or service towards the end user. And what we can see here is that, as you would expect, physicians and hospitals have always been in the top 5 positions as a main distribution channel, and it's actually foreseen to continue like that. And this is also related to what we've been hearing very recently, many times, at least I've been hearing in different forums I've attended, people saying, I see that the future is a medical doctor prescribing an app instead of a drug. So we really see here that the medical doctor will have a very important role in fostering the adoption of mHealth. But enable for you to do that, first you need to convince medical doctors to use it. Apart from this, we have the app stores, and one cannot run away from this regarding mHealth and apps. But then there are so many apps. How can one differentiate between apps right now? How can I, if I'm a consumer, how can I choose? Imagine I'm a consumer and I have diabetes. How can I choose from all the different apps that are out there? Does any of you have any idea on how many apps for health and well-being are there? Any clue? Yeah, something like that. About 97,000 mobile health applications for download that measure app stores. So imagine how hard it is to select one, right? And this is also why recently there has been a tendency from moving towards generalist app stores. for more purely mHealth app stores. And in this, here I'm showing you two, the mHealth apps, which is an initiative that is supported by the European Commission and has some interesting companies organizing it, and also Health Tab related with RX, which is an initiative from the United States. But the point here is also that you don't need to choose between going into one or the other. You can try to get into the medical doctor, putting your app also in the App Store or in the Google Play, but then also maybe you should consider this purely mHealth. And why is that? Because they help you somehow deciding what should we use. In the case of mHealth apps, we have apps being suggested by users, by consumers, by associations of patients. In the case of the other, we have apps being suggested by doctors. So it's a better way of knowing what should I pick, right? Just an example of the health app marketplace, as I was telling, apps are recommended by you. They defined a right system rating, so you as a user can also rate it, and different groups of consumers have been rating it, and it's a very interesting example of something that is being highly successful. Some apps are for free, some of them you need to pay, some are for free but you need to pay for the tutorial, so you have like a freemium model here. The other one is the health apps marketplace. It started with the health app. You can ask questions and you have doctors replying to your questions. They've recently associated that with the app RX. On top of replying to your questions, then they can say, hey, what about if you use this app so it can help you with your condition? So this part is given for free, and then you have a premium version as well that you can make consultations live with experts from different medical areas. Finally, we also all know that big companies like Apple are trying to, and Google and Samsung have been or are now trying to step up into the health and mHealth market, because obviously they realize such a huge opportunities that they have here. And recently Apple, with the new iPhone, released also what they called Health Kit, which aims at integrating and analyzing data capture from various apps and devices. On top of that, and this is a very interesting part here, they have very nice partnerships with Epic, with Nike, and with My Clinic. You probably know that with Nike they are developing kind of sensors for the well-being part. With My Clinic, you might also know what they are doing. With Epic is considered the Microsoft. This will also embrace a quality seal certification, because we'll have a set of standards defined for this, and we'll look into with a lot of detail into data privacy, because one of the main issues for users is what are you doing with my data? And we know that some of the previous attempts, for instance, for Google to step into mHealth and not working and not being successful, it was pretty much related that it was not very clear what they were doing with the data of patients. We'll start by using Google Play as a first distribution channel, but we'll also go into physicians after all. We'll make money by download of apps and extra features like the wearable sensor, but essentially through extra services. We'll have a personalized marketplace, so you enter your data and get apps recommended by you. And finally, we aim at partnering with the European Commission and also with some additional national and regional partnerships and insurance companies. So this is what we aim for with Alfred. Thank you for your attention.
Thanks, Marta. I think, okay, even though you consume all of your time, it's well, not my telephone somewhere ringing, but I was me trying to tell you your time was over. So please, someone want to make a question? Yes, Stuart.
So in this marketplace, particularly with older people, trust is extremely important. And I wondered what your trust strategy was for this application. Because at an individual level, I guess of those 97,000, how many actually have proven efficacy?
Also very few of them. I didn't look into detail in all of those apps, but I know that some of them have not been. It's a developer who developed them. They think it's nice, but it's really not being tested by users or anything. In Alfred, we'll be testing all our apps by approximately 100 users. Regarding data, we don't want to sell the data to anyone else. We just will. I'm not an expert on that part, but technological partners are developing it in the most secured way possible. So we are not doing anything with data from patients.
But trust is much more complex, just
Than that. Well, that's why also we want to involve European Commission, because sometimes it helps you and it helps. First, we want to not only to have some applications dispersed in that universe, we want to have a brand, and we'll be branding it with like silver health apps or similar name. Secondly, in recognition of the importance of the trust, we also want to involve the European Commission into this initiative. And I don't know, at least for me, if the European Commission is involved to somehow, it gets my trust. So between using any application and this one, I will go for this one.
Right, thanks. Joana.
I have a lot of questions. Maybe we can discuss during the round table in the next. But I have maybe two aspects to discuss with you. One is exactly this: the one you said, also linked to your question, is relevant to the European Commission and the fact that there is a very clear separation between app or that simply monitor data and app that gives some indication for the treatment. You show the one for diabetes released by FDA, and it's clearly completely different from the previous one because this really gives some indication. Both are in any case medical device, and I know that in FDA is recently published guidance on cybernetic applied to medical devices, while in Europe they distinguish between medical device or
it's a gray area still.
It's a gray area still, but let's say from the industry point of view, we all look where some guidance are published and then we follow. That means let's say it's really very interesting. I think it's really let's say software is already used in some cases for some specific device in relation to the pathology of the patient, the monitoring of the treatment, and also to give a feedback. So let's say I think this is very interesting, and maybe we can discuss later on this. Only another aspect I would like to ask you if you have considered in your app the UDI, because if you are going to discuss with European community, they for sure will tell you that will be introduced in the next years a unique identification for all medical devices with a barcode, which can be used, of course, let's say in this app by medical doctor, for example, or by patient to know the product that they are using. This barcode is already present in medicinal product and is introduced now in US for class 2 medical device. So I think that the discussion with the Commission, European Commission, is very important, especially at this level. But I would like to ask you if you have considered that.
From the beginning, no. First, because this is an app, it does not have a device associated. And when we look into the implementation of it, we decided that we'll start by something more towards a peace of mind function, rather than really having all the medical devices standards and having to comply with all of that. So in our strategy, we'll start by that. And then in 1, 2, 3 years' time, we think that we can move into the medical device and do all of these compliance and probably including what you are mentioning. But as a starting point, we won't be considering it because we think that we had to make some decision, and we decided to start it this way.
Yeah, in fact, I looked particularly when you talk about distribution. I don't know if I correctly understood the distribution. But if you link here the medical device used in the hospital, for example, let's say this UDI help a lot already now to work in connection industry and hospitals, service hospitals in connection to the warehouse of the hospital and distribution. I'm talking about tracking, you are talking about also tracking for implantables. This is already used in the medical field. Just to clarify that, let's say this is a very important aspect. Thank you.
Thank you. Thank you.
Thank you. Thank you again, Marta.
Thank you.
It's always difficult. Bottom-up decisions are the most difficult, as you know. So, but I know that you are all convinced that 20 minutes for the coffee break is enough. Okay. So we'll be back in 20 minutes. Morning. We'd like to initiate the second session. Please take your seat. So trying to push a little bit. I introduce you Andrea Pavlickova. She is from European Innovation Partnership and Active Health Aging, from Scottish Centre of Telehealth and Telecare. Obviously Scotland is quite big and patients are far away from each other. So we look forward to listening how you care with telemedicine in Scotland. Thanks, Anna.
Thank you very much. So my name is Andrea Pavlickova and I come from Scottish Centre for Telehealth and Telecare, which is part of NHS 24.
Please keep silent, please.
And NHS 24 is our national statutory organization responsible for the delivery of telehealth and telecare in Scotland. My primary role in the organization is management of the European projects for the Scottish Centre for Telehealth Telecare. So today I'm here more with the head of being one of the coordinator of the European Innovation Partnership on Active and Healthy Aging. So today I will introduce this initiative more in terms of the objectives, our interim outcomes so far, as well as the challenges that we are all facing together. And specifically I would like to speak about the action group on integrated care, which is the group where we see very active contribution, especially from this region, but also other Italian region. And I would like to speak more about the ICT and health services. But before then, I would like to send the greetings also from George Crooks, who is the leader of the coordination group, and he always emphasizes the importance of these regional events for the European partners who really benefit on a daily basis from your work and experience in the health and social care delivery. It's basically in relation to the, I would say, overarching ambition and motto of this partnership, and it's about working together in joint forces, which for us is the key success in tackling the issue of aging population and chronicity in Europe. So, what is the rationale for the European Innovation Partnership? You've seen these graphics from the previous presentation as well. We are all aware of the aging population in Europe and its consequences in terms of the social care and healthcare budgets, health workforce shortages, as well as health inequalities. And these challenges are not recognized on the local and national level, but equally at European level. And the European Innovation Partnership is basically the initiative of the European Commission to help to tackle the challenge of aging population based on the principles of collaboration and bottom-up approach. So basically the partnership is about new paradigm of aging, which is driven by the recognition and belief that aging can be turned from societal challenge and burden to major opportunity and asset. But to implement such a paradigm, we need to consider the empowerment of service users. We need to think about new care models based on integration and increased role of community. But also, above all, it's the partnership approach and joint forces of local, national, and European stakeholders. And the European Innovation Partnership provides this unique platform for collaboration. We have currently over 400 organizations coming with different backgrounds. So we have European Union regions, healthcare delivery organizations, industry recently, patients organizations, as well as healthcare professionals organizations. The partnership also offers a bit different approach to the issue of sustainability compared to the other initiative of the European Commission. We don't see the expenditures into healthcare as a cost, but rather as an investment which can support smart growth and economy in Europe. And I'm sure you will hear more about this when we will be hearing today about the case of Greece and how the crisis can be used as an opportunity. So talking more about the objectives of the partnership and what we are doing within this project, the overall ambition of the partnership is to increase healthy life years of the European citizens by 2 years by 2020. And to achieve this objective, we are looking for so-called triple win. So it's not only about this healthy life years and quality of European citizens, but also about sustainability and efficiency of our healthcare system, and subsequently about growth and expansion of the industry. To achieve this objective, the partnership is divided in 6 specific action, or as we call them, action groups, and each of them focuses on a different aspect. So we have the action groups on adherence, then the groups on the prevention and management of false, frailty, independent living solutions, age-friendly citizen environments, and then it's the action group on integrated care, which I will be speaking more in details from shortly. What is important to emphasize when it comes to this initiative is that it's not a funded project, so it's really based on the voluntary collaboration of the partners across Europe who work together with providing inputs, their expertise. They help us to provide evidence, but more importantly, they are willing to share their experiences, share their knowledge, and share their expertise, which can then enable scaling up of these solutions across Europe. The European Commission plays more a role of facilitator, so the role is to facilitate this exchange of knowledge and best practices, and also to make sure that there is the official platform for collaboration. And this is to illustrate how we work concretely. So, of course, the content and focus of each action group is different, but when it comes to the working methods, we can see some similarities. Currently, most of the action groups have achieved the first phase of our work, which is around, which we call mapping of innovative practices. And it's basically this process of collection of evidence and collection of good practices across Europe. The rationale is to basically bring the whole evidence that we have on in this area into one database, so that we don't duplicate and create new solutions and tools which already exist. And in the second phase, so currently in 2014 and more in 2015, we are aiming to basically turn this evidence into the development of concrete tools that could help to support implementation and scale up on the larger scale. Besides the action group, we also have so-called reference sites. Currently, we have 32 regions, cities, or also like integrated hospital units. And basically, these reference sites are the organizations who have already received the recognition for the innovation. They can provide the evidence, and they are ready to coach other regions to implement similar innovative solutions. And as you can see from the map, even this region, Emilia-Romagna, is part of the reference sites already. So now a few more details around the group on integrated care, and I will introduce or present our outcomes more from the Action Area 7 on ICT and teleservices. So the B3 group has, I would say, very ambitious overarching objective, which is to reduce unnecessary hospitalization through the implementation of integrated care programs and chronic diseases management programs. We have two targets. By 2050, we would like to see these programs in more than 50 regions in Europe, and by 2020, in additional 20 regions. And similarly, as in case of, as illustrated in the case of action groups, we follow a similar pattern of working. But what you can see in the left part of the slide is that we are organized around 8 action areas. And these areas were identified by our partners as the key drivers for the integration, and but at the same time as the key obstacles for the integration. And I will speak more about the Action Area 7 on the electronic care records and teleservices. And I had the pleasure to coordinate this group, but I also pick up this action area as an example of very active contribution from the Emilia-Romagna region, who is one of the coordinator of this action area as well. And we receive very strong support in terms of the evidence collection, contribution to different strategic documents such as recent mobile health consultation from the European Commission, or we are currently working on the recommendation in the area of standardization. So I would like to use this opportunity to thank again all the partners from the Emilia-Romagna region for the support, as I see all the faces from the group here as well. And this is to illustrate what we are doing concretely in the Action Area 7. So in 2013, we concentrated our work more around this collection of evidence, and currently I think that we are in a more exciting phase where we try to turn it into easy to use tool, and for us it's we call it like maturity model, and I will explain a bit later. But just as a kind of like a journey where we start, when we met 2 years ago, we had the main issue around understanding what are actually the information and communication tools and services which are key for the integration, and what do we mean by services. So we started our work with a definition of the services which we consider as a key for integrated care, and also we not only listed those services which are important, but also categorized if the service is important to achieve vertical integration, or is it more about horizontal integration. And also in the third column you can see that we try to identify the level of importance for the integration. So this was for us like starting point, like a consensus framework. In the second stage, we then looked for the evidence in Europe, so we collected good practices, and we tried to link those services to the metrics that I presented before. This process of collection of good practices is still ongoing. Currently, we have over 50 good practices, and we are trying to look more in details in these practices. So just to illustrate what kind of building blocks and what kind of information we try to collect, I've picked up the example of e-services solutions from Emilia-Romagna. So basically, coming from the action area on ICT and teleservices, of course, for us the critical is to understand the infrastructure around that particular service, but also the environment, but also the issue of environment, how the environment looked before the introduction of the service and afterwards. And I think that what is the most critical part of this analysis, especially when we look at the objectives of the partnership and integrated care group, which is about scaling up innovative solutions, I think that it's an extremely important part of the work is around identification of barriers, but also stories about how these barriers were overcome by the concrete region and what other regions can learn from these examples. We have so far analyzed over 40 good practices, and we are summing it up in form of the reports which will be available mid of November. Now I would like to speak more about tools. So it's a, how we call it, maturity model for us. And basically the main rationale for this activity was this understanding and recognition that the ICT solutions are adopted at different level. In Europe we have the progressive regions and then less developed regions. And we pose ourselves a very simple question: why is it that certain regions are more successful than others, and what we can learn from those pioneers, and more importantly, how we can maybe structure this knowledge and outcomes in a more structured way. So this is why we decided to work on the maturity model. We conducted face-to-face interviews in 6 regions who are active participants and partners in the European Innovation Partnership. We have 3 more developed regions, so we have the Basque Country, Catalonia and Northern Ireland. And then we had less developed, so we had Attica, Saxony and Galicia. And we asked all the regions the same set of the questions, which were more around their e-health assets, teleservices and programs. And we tried to abstract what were the common themes that appeared for the interviews. And basically this resulted in the draft version of our maturity metrics, which consists of 10 dimensions, which are for us critical to achieve integration with the support of ICT. So you can see there the dimensions such as readiness to change, the importance of governance, structure, capacity building, but also removal of all of the inhibitors, including legal one, that hinder the integration. And then we went more in details, analyzing what each of these dimensions means for us and how we can actually measure the maturity around these dimensions. So this is for us in the 3rd column, so-called maturity indicators. It's still in the drafted version, and what we are trying to do with it now is to basically figure out the process and methodology, how we can turn this work into B3 maturity model, or better saying self-assessment tool, which would help regions to position themselves and basically compare with the other regions how well they are on their journey towards integration. It shouldn't be the scoring tool, but rather the tool which will help the regions to see their strengths parts, but then also their weaknesses. And with the evidence that we've gathered through the collection of good practices, but also through the reference sites, we would like to then provide tailored recommendations for this region. The ambition is to present this self-assessment tool end of this year at the partnership conference in December. And in 2015, we would like to test this model in practice. So in terms of next steps and future challenges, basically I mentioned that the partnership and especially the action group on integrated care really aims for scaling up and replication of innovative solutions in Europe, and there is a recognition that the partnership really can be the tool and catalyst for this scale up. Partnership, its added value is the existent database of evidence. So we have the resources and expertise, but now the question is how you can move this expertise and resources to reach the scale. So how we can bring all this knowledge from the local level at the European level. The European Commission has produced the strategy for scaling up, which is still open for the consultation, which should give us more answers to the questions what to scale up and how to scale up. What we are aware of currently is that the fact that we gather the evidence is definitely not enough, and we need to go more in detail to understand what are the elements of these good practices that we can actually move from one country to another. But what we see as the really driving force for this scaling up procedure is this partnership and joint forces approach of all of the partners in the project. So just to summarize, you probably heard a lot of those comparisons in this conference, that the partnership is compared to the ship, that it takes a lot of time till you start the boat, till you gain the speed, till you get to the harbor where you want to go. But still people get on the board because they think that there is something for them at the end. And we believe that after 2 years of working in the partnership, we are on the proper direction and way. But we of course understand that there is still a need to do and to go. But so far what we can see from the feedback and from the participation of the partners in this project is that really the main added value of the partnership is about providing this platform for learning from each other, exchanging the knowledge, exchanging the evidence that we have, and basically working together also help us position stronger when it comes to the application for the funding. We also see a creation of a lot of regional partnerships and memorandums of understanding as a result of the participation in this project. And lastly, I think more importantly, we gain the political support not only at the European level. There is, of course, strong support from the European Commission and the possibility to feed into the European Union strategy around the healthcare, but also recently what we can see, for instance, in case of Scotland, is the political support at the national level for the agenda on active and healthy aging. Thank you very much for your attention.
Thank you, Andrea. I'm afraid you overuse a little bit your time. If there is any quick question. Otherwise, thank you very much again. Thank you, Prof. And I invite Licia Boccaletti. Technology impact on caregivers. Please, Licia. I help you, and if you hear some noises from this side, it means that you are about to finish.
Buongiorno a tutti, good morning everyone. My name is Licia Boccaletti. I represent here Anziani, which is an Italian NGO working in the field of informal carers, and also we are active members of Eurocarers, which is the European network of organizations supporting informal carers. So my task this morning is to give you briefly an insight on the impact of ICT tools on informal carers, because most of the time we concentrate on end users, so older persons or patients, which is correct of course, but it's very easy to forget the impact instead on informal carers. So first of all, who are carers? So this is the definition which is adopted by Eurocarers and which is the one commonly used at European level. So a carer is someone who provides unpaid care to another person who has a chronic illness, disability, or in any case which is dependent because of health problems. And this is done in an informal way, so we are mainly talking about spouses, children, friends, so people who do it on the basis of the relationship they have on the patient. And I always like to quote this sentence from Rosalind Carter, because I think it makes very clear that we all have to pay attention to the topic of informal carers, because in some stage of our life we will be carers ourselves, or we will have a carer helping us. So it's everybody's business, I would say. It has been said before in the presentation of Stuart Anderson that in Europe, carers everywhere, even in the most developed European countries, are those providing the largest amount of care. So the estimation is that in average, they provide 75% of the care volume. Carers are over 100 million in Europe, mostly women. This is quite easy to imagine. So it's also a gender problem. And very, very often it is forgotten, and I really appreciate what was said during the previous presentation about that the economic value of the care they provide. So if we dedicate 1 minute to calculate the equivalent, the money equivalent of the care that is provided, it will become very clear that there is a clear need to support them if we want them to continue providing care. In fact, this is a figure from the UK saying that very soon in the UK we will reach this point where the number of carers will not be enough to provide care to the persons in need. So it's not basically an endless force. So we have to pay attention to support them if we want them to continue providing care. In average, a carer provides care for 45 hours per week. And the length of the care, it's very long. Normally, in average, it's 5 years of care which is provided in chronic conditions. So I think it's quite easy to imagine the negative impact that this can have on the life of the informal carer. There are many evidences, many researchers in this field, saying, for example, that there are impacts on the physical and mental health of the informal carer. That there is a high risk of isolation, and also that this has a negative impact in the income. For example, there is a higher risk of poverty for carers, and also on the work opportunities. So even when the care comes to an end, it's very difficult for an informal carer to go back to a paid job. So now the question is, can assistive technologies help carers? So of course, yes. For example, if the tool, the device, allows the dependent person to perform some things by himself or herself. So let's think about, for example, the domotics, which is already very common: turn on the lights, shut the curtains, do the shopping from the internet. It means that the carer will be a bit relieved from providing this task. So of course this is a good point. Also, from the point of view of carers, very useful are all those tools that allow to monitor the patient. Let's think, for example, about patients with dementia. So they have, you know that they, for example, they have wandering problems, that they have to be monitored very carefully, basically 24 hours a day. So at least in the earliest stage of dementia, if this monitoring can be done remotely by the carer, of course this will mean allowing the carer more freedom to move, not to be, they would not have the need to stay closer to the patient all the time, and also it could be a relief in terms of stress. Psychologically, they can check remotely that their care recipient is doing well, so they can be a bit less anxious and more relaxed. And then, of course, there are all those tools and devices that allow the care recipient to be cared for at home instead of in hospital or in a residential facility. And this is, of course, again, a positive feature, because it's not only a matter of reducing the cost and allowing the patient to be discharged earlier from hospital, but I think it's a common experience that we all prefer to be taken care of at home instead of in a hospital or in a facility, and this is true also from the point of view of the carer. And finally, the positive side, I would mention the fact that ICT can help carers prevent isolation, so giving opportunities for social networking, get supports from professionals but also from other carers, getting information, accessing training. These are all important things to prevent isolation and burnout. So these were the positive things, but I would also like to give you some, to point your attention on some remarks. Because it's, for example, when we test a tool with carers, most of the time we get positive feedbacks on the tool, but we have realized that in some cases, we have to be careful, because in some cases it's not the device in itself that is really appreciated, but it's the extra attention that the carer receives during the training, so the testing period. So they feel they are important, they feel they are listened to, someone is visiting them. So this has to be taken in account. I think from your point of view it's useful to remind that, because when you test a tool, you should take in consideration this fact. Also, another point I'd like to underline is that for end users as well as for carers, it's very difficult to orientate themselves in the market. There are already many devices which are available, as they have been mentioned also in the previous presentation, and it's difficult for them to understand what's really useful, so where maybe they can invest their money on. So they need to be supported in this phase. They need to be to receive counseling, orientation, so in order to choose those tools and devices that can be really useful for them. And then not only the care recipients, but also the carers themselves. In most cases, they are older persons who are not familiar with ICT, with technology, and if the technology we offer is not easy enough, user-friendly enough, the risk is that we give them an additional burden instead of a support. So it's very important that they receive adequate training, but also that the tools in themselves are easy enough to use in order not to become another burden in an already burdened life. Again, because most of you are working actually in the field of developing new tools, new devices, and you will test them with carers, with patients and carers. But it's really important that it is taken in account also the whole, I would say from an ecological point of view, the whole environment where you are acting and using your devices. And we recommend that the development of the tools is driven by, not only by the end users, but also by the carers themselves. Carers are sometimes, in the best cases, involved in the testing, but very rarely in the development stage. So I would recommend to all of you who are thinking and developing new tools, targeting older persons or persons with disability, to involve also their carers in the development stage. So that was my presentation. Thank you.
I think you'd like to give some more information about an ongoing project.
I will take 2 more minutes of your attention to tell you that our organization, together with Democenter and many other actually partners which are in this room, are involved now currently in a FP7 project concerning the development of clothing and textile answering to the needs of older persons, so the aging society. The project is called TAPS. TAPS has a poster in the poster room there. And we of course invite you to have a look at our poster, but also we would like to ask for your help. There are, near the poster there are these really colorful cards, where we would like you to write down, if you wish, your inputs concerning the topics we are currently working on, which are hygiene and therapeutic textiles. And we would really welcome your inputs in terms of problems that you have identified in your works concerning this topic, new ideas, policies or recommendation of practices that could be useful for us to be aware of. And at 5:40, we invite you to join us in the tax room, which is on the other side of the courtyard, so you exit this room and we are on the other side, because then we will gather all the cards and comment them in a short focus group. So if you are interested and if you want to come, you are very welcome to do that. Thank you again.
Thank you very much. Questions or queries? If not, thank you. And let me invite the last speaker of this morning session, Theodore Volpetsianos. He's from AHA Greek Network Coordinator, Best Practice in Greece, in Greek, Stakeholder Initiative in, okay, sorry, I'm reading Italian, so initiative, so you speak Italian.
Thank you very much. I would like first to thank the organizers for the opportunity of being here and having the opportunity to present what kind of initiatives we have been taking in Greece in the topic, in the domain of elderly and chronic patients care. After the very well presented introduction of the previous speakers, I would like to be more specific of what kind the initiatives we're designing. Several organizations in Greece have a good penetration in European projects in the R&D domain. These are some geographical distribution of these pilots in Athens, in Thessaloniki, in central Greece, and in Crete. Here are some examples. This is from Crete about Frailty syndrome. Another one from Athens about Alzheimer's disease. Another one regarding telepsychogeriatrics. And another one from our hospital. Please allow me a few words about it. We are trying to give examples in practical terms in the real life how the hospital-centered care, which is the reality in our country, on the left-hand side, can be modified in patient-centered integrated care using technology as an enabler. We have made some pilots with very good results, providing that we are starting from a low level. And this is a recent work about hospitalization on chronic respiratory patients. We have accredited from several European organizations. We have been presented as a good examples in European Union, but the question remains, and it's clear. You are quite good in pilots. So what? What next? This is a real question. So we try to put pressure on our political leaders. Here is our Secretary General of our Ministry for Public Health, who in the Brussels Conference of Partners of EIP initiative announced the formation of the Greek chapter of this European initiative. And we have started to be a separated legal entity with supported from the ministry, but quite independent to make any kind of collaborations we would consider as useful. Here is the expressed interest from several sectors. You can see it in our website, from academic sector, from public sector, social, research, as well as private sector. It has been a strong interest, and all these actors are making these kind of thematic subgroups. Here is the main names of our groups, the coordination of all these fragmented trials, the alignment of what is being in action in European landscape, as well as the affiliation, the official affiliation with other regions in Europe to make strong collaborations. We have so far mobilized the interest of several stakeholders, like health and social care personnel, informal carers, patients association in Greece, as well as industry. So far has been a strong interest of rehabilitation centers, innovative home care providers, medical devices providers, construction agencies, as well as ICT companies. Affiliations with other EU regions, the initial discussions have been with Scotland, as Andrea mentioned before, as well as from Catalonia. Here is an official meeting regarding the affiliation with Catalonia the last April, and here is a meeting between the ministers in e-health forum in Athens the last May. We are trying to show and to attract interest from several European projects, as this one is regarding the chronic patients, the main guidelines of chronic patients care at the level of Europe. And finally, and to my point of view, the most important, to propose a large-scale integrated care trial at national level in the reality of everyday clinical practice. This is an initial scheme combining public hospitals, three main public hospitals, the charity sector, who is quite active in Greece, fighting the crisis, as well as academic sector. But also there is a strong interest for participation, for active participation and funding from the private sector, as I told you, as well as from several organizations from social sector. The European affiliations that I mentioned are going to help us in design and improving what we are trying to do. So in this large-scale pilot, we are going to identify the key driving forces as well as the dominant barriers, as well as to make the needed clarifications about sustainability and business models. We think that the reimbursement schemes are of major strategic significance, and we are taking into consideration the trends in these current reimbursement schemes, which move from reimbursing the value instead of volume. They are going to replace the fee for service with a bundle-made payment, as was referred by Joana previously, as well as making active partnership with the healthcare providers, leaving behind the traditional provider-payer relationship schemes. Finally, I would like to especially mention that there are people and teams in our country believing strongly that innovation is a good opportunity to fight the crisis, and we would like to invite other teams, person, organization in Europe. That's why we're here, and have the opportunity to interact with the people here, to invite for collaborations. I have the opportunity already to meet two wonderful Italian ladies who speak Greek better than me, and we agreed, really, I mean it, and we started to make the initial discussion for another affiliations too. Thank you very much.
Thank you very much. Your contribution is open for discussion. So, from pilots to spreading
the difficult task.
It's not so easy right there to examine. And if not, I think that there will be ample, as you said already, possibility of discussion here. And you earned your lunch today. So, we finish this first session of the morning. We reconvene here in 1 hour. Audience starting the lecture, perhaps. I do understand that you enjoy meal in comparison to our usual meal. It's quite different, but nonetheless we have to do and go ahead, otherwise tonight you will not enjoy anything else, right? So, right, whatever it is, may I invite Kai Laxenring to start his lecture. He will have some patience, he will start off slowly, right? And so I will allow him a few more minutes, obviously, but please, Kai, start. Otherwise, we never start.
Yes, good afternoon. I will start slowly and go perhaps one step back to what the previous presentations have shown, that there are many opportunities in integrating health and social care with the aid of ICT and all kinds of technologies. But I would like to go one step back and ask you, or try to discuss with you, what we really mean by integrating health and social care, and what the role of ICT and technology as such could be. So I will start my presentation with arguing for the need for integrated long-term care and show some opportunities for innovation in this area, and also show you some practice examples, especially focusing on the role of ICT in these innovation processes, and finish with some suggestions about governance and financing of innovation in long-term care, because investment will be needed, mid-term and long-term investment will be needed, but I also show that this investment has good chances for returns. So starting to talk, because we heard a lot about health this morning, Licia then brought the discussion more towards long-term care and the role of informal carers. But what users in this area often experience is that they are thrown between different systems that have different rationales, different approaches, like on the one hand the social care system, on the other hand the healthcare system, and which is often mainly focusing on hospitals, on disease, on curing, and has had a lot of success, and this is also one reason why we have this increase in longevity and why we have aging societies. So users are experiencing this health social care divide, and perhaps also you representing industry are often experiences this divide in terms of funding, in terms of regulations, and so on. I have advocated together with a number of colleagues for many years the thinking about long-term care as a system of its own, be it linked in, coordinated, integrated, however you want to call it, but it has a special identity, and we see emerging policies in this area, structures that are dedicated to long-term care, specific processes, quality management, and also specific means and resources that, of course, are still much less than we see in the healthcare system. And my argument is that often users end up at the wrong place at the wrong time, and often in very expensive healthcare settings. And we could improve something by moving and guiding patients or clients to other settings that are better for them, and also for all of us because they are less costly. What is another important feature of long-term care, and Licia has pointed out this already, is this formal and informal care divide. Actually, this lower part should actually be 80% of the slide, because this is what informal care is giving to long-term care. So this is often informal carers, family, friends, or volunteers, and we are still far away from really integrated long-term care systems. Just to give you one hint, what is why this system is still deficient is the phenomenon of migrant carers. If we are in Italy, I might perhaps inform the not Italians that I think the most important app or software that is used by Italians at this moment in this area of care is an app that helps you to administer, pay, and so on your migrant carer. In some regions, there are 30% of people with long-term care needs that are cared for by migrant carers. These are people often from Romania, Ukraine, and other third countries that are living in the family and providing 24-hour care. And this, for me, is a clear sign that something in this system doesn't work and needs innovation, also in terms of reintegration into the system. So to sum up, we have had a tremendous success of health systems in curing diseases, but we have seen problems of this system to deal with the consequences of aging and of the success by having people living longer and many years with multiple chronic diseases and long-term care needs. Informal care is still the backbone of long-term care, but also here we see that we have difficulties with the increasing burden and the multiple expectations and role conflicts that are linked to informal care by family members. And we have seen in the end an acknowledgement of long-term care as a social risk in most European countries. But we still struggle, all countries still struggle with overcoming fragmentation. Scotland has shown this morning a very intensive initiative to overcome this, and we see in many other countries projects that are looking at this. But actually what we need is social innovation in terms of new solutions that also meet these social needs and challenges and lead to improved capabilities and relationships to better use our assets and resources. So this type of social innovation, apart from the technical and technological innovation, is needed in order to underpin the technological innovation. Because one question of this conference is also why, as we have so smart solutions, why don't we use them? Why aren't they applied? And I think that we have to look at the different countries, the different cultures, and the different stages of development of long-term care systems in the different countries in order to understand or to answer this question. Because we have seen, we are currently doing an EU project called MOPACT, where the idea is to mobilize the potential of active aging in Europe, also in the area of long-term care. And there we see that in some countries, of course, the development of innovation reflects the current development of the country systems, like Hungarian and Czech colleagues who came up with elderly-friendly housing and tele-alarm systems as most important innovations in their countries, which in other countries have already been introduced many years ago. In Italy, an innovative project is looking at the recognition and training of informal care skills. Saying that actually if you are caring, you are developing skills that should actually be acknowledged and recognized officially. We see first steps towards Telecare in all countries, so less, apart from Telehealth, we call Telecare ICT applications that focus on the area of care. And we see new ways of community-based home care, and I would like to shortly go into these projects. Well, this is something we have heard already about in the virtual elderly care service. Here, a software has been developed in Estonia and Finland, especially for remote areas. Of course, this is important to have these kind of devices. Also for peer socializing in the home to prevent social isolation, or to increase access to professional services. But you see, this is a very small project, and there is a potential, of course, to be scaled up, and the use of ICT can facilitate the expansion of these kind of services, and also of formal care services linked to the needs that are assessed by means of this Telecare application. But in fact, and this is what we most often see happening in this area, that the projects are funded for 3 years or so, and then when the EU-funded pilot is over, there's lack of funding for the future. The other area would be kind of a new market, of course, is also concerning ICT and training, and in this case, the recognition of informal skills, as I said before. We have here opportunities for telelearning and new applications to match supply and demand. In this case, this is also mainly focusing on the already mentioned migrant carers in order to integrate them more into the formal care workforce and into the formal care service system. The use of ICT can enhance the documentation and communication between stakeholders. You can see really who has gained which type of skills and how can these be used in the formal care system. But also here we have a lack of funding and partly a lack of involvement of industry. But I think this is nevertheless an idea. Also in terms of developing employment in this area, further developing employment in this area, that should be further taken into consideration. And finally, we have also new models. We need new models in providing care. Because telehealth and telecare is all very nice, but even the most globalized and technological person being in need of care, sooner or later will need somebody to change the diapers, to help out of bed, to pay the bills, and so on. And so we still need the hands-on care, and how to organize this will be one of the most important challenges in long-term care for the next 2 or 3 for the next decades. And here I would like to open an opportunity that has been shown that changes can really come very quickly and spread very quickly. Like this example from the Netherlands, where a non-profit organization called Buurtzorg reinvented home care in a way, starting from the observation that older people don't want to have 10 different people per week in their home. And the usual organization in home care in most countries is still very tailorized. You have a home helper, then the nurse comes in, somebody brings you something to eat, and so on, at best, if you have the services. This group of community nurses started to think about how to provide more holistic and more integrated care in the community, and they formed autonomous teams of 10 to 12 nurses that take responsibility for a defined neighborhood, also in a preventive approach. They started with one team in 2006-07, and they grew over the past 7 years now to more than 600 teams and more than 7,000 staff. And they forced all other providers to work more or less in the same manner, because otherwise they wouldn't get additional staff. So here, this is an example where you can really see that also with the support of ICT you can reduce costs. With the support of organizational change you can reduce costs. In this case, the costs were reduced by at least 40%, as was shown by several studies. And so here, for example, the 7,000 staff are supported only by a small back office of 50 people and ICT also helps to enhance communication between the team members and between the teams. This is, I think, one of the most innovative examples in Europe concerning home care and the redefinition of integrated care on the community level. So to sum up, the role of ICT in enhancing long-term care delivery can be very important if it takes care of the specificities of this sector, because it can enhance the expansion of formal care services and improve their effectiveness. It can simplify the complex processes and especially communication processes that are needed to really integrate long-term care and to reduce overhead costs, and it can enhance, of course, documentation and communication between the stakeholders. So also social networks will play a more and more important role in this area. The drivers are really that we need to govern the specificities, as I have outlined, of long-term care, moving from a biomedical model in this area towards fostering quality of life. The health system is very good in curing, but to care for a longer term and to care for people that cannot be cured, it has a supportive role, but we need something that is more focusing on developing the quality of life. And we have to overcome the health and social care divide, be it in terms of funding, and I was very happy to read the example that was presented about bundled funding in Greece, and to overcome also the formal-informal care divide. So I think these are important issues that have to be taken into account when developing ICT and other innovations. And we have to acknowledge clients and informal carers as co-producers, co-designers of care processes, as also Licia has underlined. The role of ICT can, of course, be boosted with a return on investment in terms of creating new jobs and also new job profiles. We don't just need more nurses, but we need specialized community nurses that are able to provide holistic care, perhaps with the support of ICT in the local context, and we should use social networks for better care coordination, because we often it is said, well, we can rely on the family. Actually, we cannot. We need to develop this much more intergenerational, multicultural, and community-based beyond the usual family bonds, because these don't hold anymore in many countries, and we are still closing our eyes in front of that. And of course, we have a number of new products in this area that can be created, and markets that have to be developed if we develop long-term care as an own system together with all the relevant stakeholders. If you want further information about this approach to integrated long-term care, here are some links and literature, and I'm happy to answer your questions. Thank you.
Thank you very much, Kai. The contribution is now open to discussion. Please. It counts.
So I just wanted your view on this. I don't necessarily advocate it, but
one argument might be that we should just completely marketize this, yeah, and say that ICT will enable us to create a market in care, and then this would make the value of care visible, and you can bid into that market in a variety of ways, because we now see these new e-labour markets emerging all over the place, and that's the way that we should go. I'd just like to hear your opinion on that.
I didn't understand this.
The issue is, one of the important things is that informal care is invisible.
Yeah.
And there are things, I mean, if you look in the area, for example, in software development and so on, there are these e-labour markets emerging where you have people offering work to be done and then people taking it up.
Yeah.
One possibility is to build a mixed market where you have all care needs. Yeah. And then what you do is you make the care demand visible, and then you have to meet it in a variety of ways.
Yeah, but in a way, as I said, I think this phenomenon of migrant carers, not only in Italy, we have it in Austria, in Austria it's a bit more regulated, in Germany it's not regulated, we have other countries where you don't even speak about it. This is the area that makes the need for long-term care actually visible, but again in an invisible way. And I don't know what role ICT could play. Actually, currently it plays. Perhaps we could check these websites of where you administer your migrant carers. How many people are really registered there to make this visible? But actually, people are talking about this phenomenon as if it was a kind of normal service. But actually, it is very strange that you have somebody from complete stranger living 24 hours with you suddenly, and also for the carer suddenly being in a foreign country with somebody he didn't know before, and is now living together 24 hours. And I think there is no real, well, if you want, so this is Manchester capitalism market, because this is a market in its crudest form, and not regulated. So we still need to go one step further to really make informal care and what is really performed there to make this visible.
Yes, I suppose that's what I was saying, that actually having a market in all informal care would make this visible.
Yep.
And that would include not just migrant care, but also care
for
other family members, for example.
This is partly reflected by some schemes in some countries where carers are funded, are paid by, for example, in some Nordic countries, family members can be employed by the municipality, and also in Romania there's a scheme like this where family members are employed by the municipality to care for a family member.
Right, sorry to interrupt you, but I'd like to try to keep it to the time, otherwise tonight will be very late. So a very interesting point. And obviously the discussion might go on. Also, behind the scenes, thanks a lot. May I invite the next speaker, Thomas Olesen? Where is Thomas? Yeah. I think, if I'm not wrong, he's the first representative of a company, right? Which is, I think, on the line on what we want to do. I mean, meeting companies, private companies like Qualcomm Life, which I think is very well known in the world, now with initiatives, research, European officers, and so on. So, is it up to you, Thomas?
Thank you very much. Can you all hear me? Yeah. Thanks very much for the invitation. It's an honor to be here, and thanks for arranging this conference. I know how much work that takes, so great honor to be here. And I wasn't aware that I'm the first representative of a company.
Right, today.
Today, yeah. So I hope that's interesting for everyone as well. You also said that we all know Qualcomm. My experience when talking on conferences here in Europe is that people don't know Qualcomm. So are you aware with, or do you know Qualcomm? It's perfectly okay to raise your hand if you've never heard of this company. Okay, so good to know. I just like to understand before I start talking. Okay, very good. Good. So let's just do the overview. It's often a surprise. It's actually a big company. It's a global company. It says $25 billion revenues, and it's actually in 2013. We just finished the financial year 2014, and we're close to now $30 billion revenue. To say very high level, I think everyone knows the company Intel that makes technology, chips and so on for laptops and desktops. That's what we are for mobile. So you have our technology in your pocket right now, most likely. Any smartphone in the world is equipped with technology from Qualcomm. Any tablet that runs on the mobile network would also have the Qualcomm technology inside. So that's the world we live in. We love mobile. And then there's some more figures up here. This says that there's more than 1 billion smartphones shipped in financial year 2013 with the Qualcomm inside. So this is both Apple phones and Samsung and Sony and all these things. Why is this interesting to healthcare or integrated care or e-health? Or we love to say mobile health because we like mobile. We are the world leaders in connecting something on the mobile network. What we do in healthcare is we use this core competence to connect medical devices, medical apps, all kinds of medical stuff where you need to get data from some place or some location into the healthcare system, one way or the other. That's very broad, and I'll go into more detail here. It's an American company headquartered in San Diego. Americans, well, I'm Danish myself, but Americans always love to talk about mission and vision. This is it. And this is what we do across many other businesses. We mobilize things. And in terms of healthcare, we are here to create access to healthcare anytime and anywhere. And I think we're one of the companies that actually do what we say. There's many people that say mission and mission, and then they just say it. But this is really what we do. And we do it in the company called Qualcomm Life. This is not a huge company. This is a division that started up 3 years ago. Kind of a startup with a little more than 100 people, but leveraging again the core competence of the corporate Qualcomm into healthcare. Make sense so far? All right. This is still a little bit high level. Is this fixed? Can I move with this? Oh, I'm not going to break something now. This should be wireless. This should be mobile. All right. Here we go. Sorry about, is that better? Okay. I'll put it back. Thank you. Is it on? Yeah? Good. There actually might be Qualcomm chips inside here, so we just run it. That's another thing. High level, what we're seeing and what we're seeing today is there's so many things happening in integrated care and telemedicine in terms of developing new services, new applications, new smart devices, all kinds of things is coming into the market through a project or a company doing something or a mix, but it's happening really quick. I think we also know about wearables, many new things coming, smart watches, patches you can put on yourself that's measuring your condition and all these things. That's many different data sources, and this can be difficult to handle in terms of making an effective outcome. When I say an effective outcome, I mean the most cost-effective solution for the healthcare sector. Today it's not sustainable, it needs change, it needs innovation, that's what we're here for. So really what we want to achieve here with our platform, and I'll get into more detail, is what everybody's talking about. It's really decreased cost, but better quality of care. On the other side here, that's where we try to illustrate all kinds of devices, apps. There's also a lot of data already hidden in repositories in some countries that's been measured over 50 years with kinds of statistics on population in Germany, in Holland, here in Italy. All this data is just growing rapidly with all these new devices. This needs to be accessible in an easy way and be able to mix and match these data sets to create new, unique services and better outcomes on the other side. That's what we try to achieve here for our partners with our service platform, which we call the TUNET platform. I'll show a little more detail. Does that make sense so far? So, what you saw here, devices, for example. What you see here is a lot of different devices. We have already integrated all the standard medical devices in the system. So this is infrastructure where our partners who would have some application, this could be a startup company, it could be a medium-sized, it could be a big global player. But even for global players, it's really challenging to handle all this infrastructure and make sure that the devices out in the houses and the homes of the patients keep working with the highest service level. I think there's a lot of projects that show that you install something and then they do a couple of measurings with one device, then they do another reading with another device, and suddenly things fail and the patient maybe needs to connect with Bluetooth themselves and so on, and it's not working that way, and the project fails. People don't want to do it. It has to work all the time, just plug and play. That's what it does with all these are just examples of difficult devices here, both medical devices, but also consumer activity devices and so on. And then there's a smartphone here. Already we integrated all the Android devices in the system and iOS devices. So this means for any one of you who would be looking at developing an app or an application, you don't have to worry about which medical device or which sensor you want to use for your service or for your product. And you don't have to worry about which device here. There's also something here called, we call it the TUNET Hub. It looks really big on the picture. This is it. I think there's a lot of applications for chronic ill where it doesn't really make sense to use smartphones. Many of us say smartphones are so simple and so intuitive. If you never had one in your hand before, and you're 80 or 90 years old, and suddenly you're supposed to play around with this, I don't think that's really intuitive at all, regardless of how this app works. Maybe I'm wrong. And there's a lot of people in Qualcomm that hate me for saying this because we like smartphones. For those people, we have this way to install this. Is there a power plug somewhere here? I don't know. But you plug it in the wall. Yeah, okay, there's a plug down here, nobody can see it. You plug it in, and that's the way to install it. When that's done, you have your home medical hotspot up and running on the patient side in the home. I can go into more detail on how that actually works. Can everybody hear me now? Because I kind of sense that this is as loud as this one. No problem in the back? Yeah? If you don't hear me, raise your hand. Okay. Okay, so a little bit of detail here how we work. Here we try to illustrate all the medical sensors. This could be apps, but it could also be medical devices. Most of them today are starting to use Bluetooth. Bluetooth Low Energy is coming. Some use Wi-Fi, or some is connected with a USB cable. It could also be an N+. There's also Zigbee. We didn't put it up here, but that's also an option. And of course, we comply with the Continua guidelines as well. I think there is a talk from Continua, maybe, but Qualcomm was actually one of the founders of the Continua Health Alliance. But that's on this side. The medical device connects with normally Bluetooth into the smartphone or the hub if you want to use this. From here on, data goes over the mobile network onto the service platform. This is really the key service that we offer here. From this service platform, all of our partners, and we have hundreds of partners with all kinds of apps, medical applications that we try to illustrate out on this side, that have access to the data from whatever medical device they want, or whatever sensor, or whatever app. We make sure that this data is going over the system as intended, as described by the device manufacturer, or as needed by the service provider, the application developer here. Make sense? There's some very small text. I don't know why we made it so small, because this is really important what it says down here. It says everything here is certified according to the medical directive. So this is all a medical device registration, compliant with the medical directive, also FDA. And not just that, what's even more complicated, I think, especially across all the European countries, are all the local rules and regulations for patient privacy. This is different from country to country. And it's a pain in the somewhere for everyone who wants to scale up, because you have to comply with all different rules and regulations for each European country to move this data. Qualcomm is a big company. We invested millions up front to make this happen, so this is already available, which means you don't have to worry about this problem anymore. You can now focus on developing the best possible app and service, whatever you focus on, and that's what we believe should be happening. We don't think people should be worrying about standard infrastructure. This is not a parameter for competition or whatever. This should just be available just like the internet. So you would call this the internet for medical data. Alright? Actually, people would probably think, how do we do this? In this system here, we see the numbers of the medical devices. Each device has a unique serial number. Each smartphone or hub, whatever you use as the gateway, would have a unique serial number. That's already a unique data set. The reading from the device is recorded in the system along with these serial numbers. That's now a package of data, and then the time that this reading is taken. That's all that we can see in the system here. We don't see the patient name, the patient profile, the local registration in this country of the patient. We just see this is patient number 17 as example. We pass that on to our partner. They put this patient number 17 and pair it with the patient profile locally in the healthcare record or whatever service they deliver in the given country. This type of data is anonymous, so this can travel all over Europe, no problem. Maybe other countries as well, but so far within Europe, we have spent, and we still spend a lot of time with all kinds of bodies and regulators, making sure that this is always compliant. And we get, especially because it's a big American company, like Google, like Amazon, and so on, we get a lot of very critical questions on this and what can we actually see and what we have access to. This is anonymous, and it's something, even if you hack this database, you just see that there's a, let's say, a blood pressure monitor somewhere in Europe that made this reading at this point in time. You have no idea where and who this reading belongs to. So that's a little bit detail on how it works here. What's really a challenge when we talk about scalability, I think there's so much talk about things being a project and then not scaling up. And everybody says technology is already here, it's not a problem. It's a little simplified way, I think, of saying I don't think technology was there all the time. And I know there's many other things that need to come into place with reimbursement and regulatory and all these things. But until this was launched recently, I don't think there was a technology where, let's say, things move away from smartphones in society and people want to wear something simpler. They don't want to, I mean, today we're now a society of people walking around like this 80% of the time, and then you bump into something and then we look down on the smartphone again. It's probably going to stop some time, and then it's going to be a more natural part of society. If it's a watch or something else. With this system, if you're a telemedicine service provider and you now have scanned, let's say, scaled up to a couple of thousand patients or maybe 100,000, and suddenly society changes, and all of your patients hate smartphones. What are you going to do? Is that easy? Is that going to cost a lot of money to make that change and that migration? Probably yes, but in this system, all of these things are proactively installed. So if you come to us and say, now there's this new smart technology out there, we would integrate that without extra cost. We only charge a small monthly fee per active user, per active patient per month. So you now have a scalable business model here. This is not just a slide. I mean, everybody can see that this was something that's cut and pasted into this here. But I have this watch here, and I can actually show that it's already integrated with medical devices. I can take a reading here, and it pops up, just as an example, as a demo here. So it's already in place, if that happens. So we're coming to the end here. This is an overview slide on how we work both in Qualcomm Life but in general. So what's happening here? What I didn't say in the beginning is Qualcomm is very high on investing in research and development. We invest more in R&D than Apple. Last year this was $5 billion just in R&D. Then we have a lot of people who make sure we get patents and as much as possible. And then sometimes we get some really good patents and it's a very good business. And 9 out of 10 times it's a patent on something that nobody's ever going to use. But that's the way we work in principle. So we spend a lot of resource in just taking the chance, investing, developing something. In healthcare, it's within Qualcomm Life that we develop something that's a connected solution. We offer this at this point in time free of charge to our business-to-business partners. So this could be an app developer, a service provider, small or big, but they get this new technology for the healthcare thing free of charge. Based on this new technology platform, these guys can now, there could be many people in the room, can now go to market with a smarter, more advanced solution. Could be devices, services, whatever it is, and offer this, for example, to hospitals, municipalities, whoever is the end user in this case. Of course, these end users will be paying something for this product or for this service back to these guys. At this point in time, we have a revenue share model. And that's what I said before, that the model is built around just charging one small fee per active user per month. So only at the point in time where your business starts ramping up, the cost for this system is just following your own revenue stream. So you don't have let's say, a barrier in the beginning where you upfront have to pay $100,000 to migrate onto this platform. It's basically zero, free of charge to get on board and start up. And then we have a contract where when you start ramping up, then we start having revenue together with you as a partner. We often hear that this is really a unique model. This is many times the reason that people shift, because many other companies out there with even big platforms and so on, they have a completely different model where you don't have scalability, because if there's a big migration onto a new platform, in a year or 2 years, they will come back and charge you very high rates. We don't do this. I spoke about this ecosystem, about so many partners. This should already be 500 now. We just crossed the 500 mark. This is growing quickly, in part because this very easy access model, but also because it's a brilliant platform. We really get a lot of good feedback on how stable this is and how it improves the existing telemedicine service or solution. So this is growing quickly, and it's consisting of course, all the medical device companies that we work with, and there's a lot more in line to become integrated in the next 12 months. Then we have hundreds of service providers, application providers in here in the ecosystem. There are also healthcare providers such as hospitals. You don't deliver directly from our side to hospitals, but we work with many of them to understand the workflows and build up case studies and documentation along with our partners. So they're part of the ecosystem. We also invest in some companies. I'll talk to that in a little bit. Then some other parts here. You can go in and register yourself and your company free of charge on the Qualcomm Life website. It's all free. You can become a member of this ecosystem here. So what is this practically? This is the catalog for telemedicine for Europe, for example. If you have something for telemedicine, you would probably need 1 or 2 modules more, or 3, maybe a call center partner, maybe a hosting partner, maybe a service partner, maybe all of them. All of this is most likely for any European country in this, what I call it the catalog, instead of the ecosystem. So this is why it's growing so fast, because people actually seek in here to find more partners. And this creates momentum by itself. And of course this helps us, but this is a standard model of how Qualcomm works. This is why we are in all the smartphones in the world. I mean, Samsung and Apple, they hate us for it. Big companies like that push very hard to become exclusive. But what we say is, this ecosystem is for good for everybody. So what we learn from working with you guys is applied to the whole ecosystem. What we learn from these guys is also applied to you guys. So this is win-win for everybody. Okay? I think that's quite unique as well. I haven't seen anything like this out there. I'm not objective. I work here and I enjoy it, but I haven't seen this before. This is European service provider partners. We started in Europe 2 years ago. there's a lot of different stuff here. There's much more in the pipeline, but the point of this is that you see big and small. And what you see here is these companies combined, if you look at telemedicine, they cover all the standard vital signs. So you have companies here for ECG, you have companies here for diabetes, for whatever type of chronic illness is out there. And many of these already start working together in different ways because they find out that there's modules that one company has that the other one doesn't have, and so on. Is somebody here aware of who is Tunstall company? All right, not many people. This is probably the leading company globally for Telecare, so assisted living. They have already delivered solutions to more than 3 million people around the world for home sensors, for their systems. It's pretty interesting that a company like this is shifting over to a new infrastructure. This has taken a long time because they already have a stable solution that's been built up over the past 50 years. Why is that happening? Reason for this is that even a big company like this is not able to control the scenario in the world right now where you have so many new devices coming in all the time and so many changes in the network scenario. So many new smartphones, watches, everything is changing really quick with technology. On this platform, they maintain all the existing workflows and the user interfaces, whatever they have, and then the underlying infrastructure is then replaced with something smarter, also from a business model point of view. And it's, at the end of the day, saving a lot of cost for these guys. Yep, and this is also coming to the end. So I also mentioned that we invest in this space. We invest both in medical companies, but also in consumer companies. For us, the important point is that we feel that this is a company that helps accelerate wireless healthcare, digital healthcare. So I'm happy to talk to someone as well if is interested in this part and forward you to the right people within the company. So that finishes, and back to what we said in the world. I hope that was interesting, and happy to answer questions now or later. I'll be here for the next time. So.
Right. Thank you, Thomas. Right, I allow you 20 seconds question. In the private sector, they go out of time.
Sorry.
You want to use this one?
Yeah. Just one question about the CE mark. I don't understand. You was talking about FCC mark for the system, but I don't understand if you have something for CE. Yeah. And also you was talking about dollars, but I think we are in Europe, so I think you can accept also in US payment.
We're okay with payment in dollars. That's fine. And so the question about is, yes, we are CE marked, if that's what you mean, both on the platform in terms of infrastructure, and if you want to use this hub that I showed, it's also a medical device certified. And then for the system for the smartphone will always be a consumer device, but the software that we put inside makes this talk to the medically approved platform. So it can now send data over a certified system from any smartphone. Does that answer the question? And it's CE marked and FDA approved.
Anyway, let me to cut you, but for sure Thomas will be around in the audience also later on. And so let me go on the next speaker, Bridget Moorman, Continua Health Alliance Europe. Please.
Hello. Would you like me to make up time? I can do it in 5 minutes.
No. I want you to stay
I have
within
done
your
it
20
before.
minutes.
There are many who are in the audience who know I can go for 40 minutes.
I will do some desperate signs to go out of the 20
I
minutes.
promise I'll try not to take too much time. First of all, I want to thank the wonderful hosts. Romana has a reputation for being a great place, and so far, so good. I'm very happy. Thank you. And thank you for inviting me to talk about standards. It's probably going to get a little dry. This is more of a little bit more of a technical presentation, but I'm going to try and thank you. That's good too, because I have to walk like you. But what I want to focus on is that we talked a lot about some large visions and some many moving parts and functional systems, but really what drives a lot of this is the type of data that you need and or information that you're going to use. And a lot of people have been alluding to what we call big data analytics. Am I talking too fast with translators? I said it as well. But, and in order to have that type of power to make what I call data-driven decisions, you really do need to clean up the data. You can't mix data that may mean the same thing but is not standard. So I'm going to just talk a little bit about that in very specific European projects that the Continual Health Alliance is supporting from an industry advisory team perspective. So really quickly, we're going to talk about, technical considerations that pilot regions have to think about during procurement development. Why is it important that the solutions being developed use accepted standards? How can they adopt those? Then I'm going to go over United for Health and Smart Care, what they have going on there. What are the standards and profiles that they could use but didn't? And then a quick summary. So why would you want to use standards-based solutions? We wish to promote interoperability. Now, I like this definition of interoperability. It means that you can have a system or product with another, work with another system or product without special effort on the part of the customer. So when Mr. Olafson earlier said plug and play, can you hear me? Am I fine? No? Oh, he's moving in. When he said plug and play, that's really what he meant, is that when you have a USB chip like the one they handed you in the folder today, you plug it into your computer and you just expect it to work. You don't have to be an engineering specialist to make that work. You can go further into interoperability, which is called syntactic and semantic. And really briefly, syntactic just means physically things can connect, right? So when you travel, right, everybody has different electrical plugs. You don't have syntactic interoperability. You need to have an adapter. Okay, so that's what that means. The adapter makes it syntactically interoperable, but it's not interoperable across all of the regions. Semantic means that as you exchange data, it's actually understood. So for example, behind you all, we have some translators, right? They are making what I say understandable to the people who speak Italian. So that's semantic interoperability. So kind of highly technical definitions here, but you exchange the information in a reference mode so you understand the different references, and then the content is understood as it goes across the interface. Why would you want to use standards? You want to drive down what I call long-term costs. It lessens infrastructure replacement costs, and as changes occur at different production cycles, you can take advantage of those cycles without huge interfacing costs. Really quickly, an example. I worked for Kaiser Permanente, and I integrated all of their medical devices to their electronic medical record system, Epic. And we purchased a middle integrator, Capsule Tech, to do that, and I had many different types of medical devices that I had to send information to the electronic medical record. This was back in 2005, so it was about 10 years ago. We did not specify data or messaging standards at that point because they really weren't quite mature. Now, as you would replace, let's say, a medical device on one side of the interface, I would actually have to rebuild the integration path, and that would cost me more money. Whereas if I had said, please just, I don't care who the vendor is that has the medical device, please just send me the data and information in a standard format, then that would flow to the electronic medical record, and I wouldn't have to rebuild an interface to the electronic medical record. So that's what I mean by long-term costs and changes. Information technology, I'm sure if you talk to Qualcomm, they can change their product in 6 months because it's not such a highly regulated environment. Whereas when you get into medical devices, I know in the US it's 5 to 7 years, maybe a little less in Europe. You're going to have different product development cycles. And it allows these heterogeneous environments to intercommunicate. You have flexible interfaces versus brittle ones. Like I said, that one will break. It will break when they have to change. What happens when you use non-standards-based solutions? We were involved in the Renewing Health Project, and these were specific examples that I got from the different pilot sites about what happened. They used a different vendor's glucometer, and that vendor's glucometer had a 10% variation in the reading, they had to redo all of their software to identify the ranges upon which they would actually act upon, let's say, a high glucose level. They also used a new glucometer that used an undocumented feature of the network transmission. This was actually Bluetooth, and they had to redesign their whole protocol mechanism to send the information to the electronic medical record. Use of a newer mobile phone due to market changes resulted in a redo of software interfacing to the medical device. And then use of a different vendor's medical device in the hospital without database standards resulted in a rewrite of integration software to electronic health records. So if you don't use the standards of the interfaces, when you change one side of the interface or the other, you're going to pay more to reintegrate. Now let's get into standards. The Continual Health Alliance, and I'll show a quick view of what they see, is that they have interfaces between the different transmission points, if you will, for the data. They have a personal and peripheral area network interface, a local area network interface, a wide area network versus a health record network interface. And what they do is that there are different, now this is where we're going to get into the science and technical, so you can follow me. And there's different levels at which devices and equipment communicate. Physical, data, application, network. And what they've done is they've specified standards at each one of those and actually constrained them so that you will have interoperability. So you'll see a lot of different types of standards up there. So if you're a device manufacturer or a product manufacturer, you could say, I want to use the continual guidelines, and then you would expect all of the interface information to come across in that standard format, and or to use those network protocols. And here's their architecture. So the personal device, so you have the personal device, the patient or their device. This would be in the home, so the different network transmissions in the home. And then they have what we call an application hosting device, which would be like that Qualcomm 2net that we showed you. That would be what we call an AHD. So I call it a ramp to the network, right, the big network. And then you can go through mobile or other devices, wide area network device, and then you would actually have the information go into the health record network. Another organization that promulgates standards is Integrating the Healthcare Enterprise, and they define profiles between actors and a transaction between the actors. And then those transactions specify standards between actors, and they're identified at the interfaces. So even though these are different organizations that promulgate standards, you'll find that there's a similarity into the way they structure the system, and they are specifying standards at interfaces. Some of interest in healthcare are the medical devices. They have a patient care device domain. And then, I'm going to talk about integrated care, social and healthcare. They also get into the clinical area of profiles where they talk about patient care coordination. So what types of information needs to flow between the different actors, like the nurse, the informal caregiver, the clinician, the patient. What would you expect with regard to data to go across these interfaces? If you are a healthcare provider or someone who is purchasing some type of telehealth system, you need to signal the market that you want standards-based solutions, all right? I'll be honest, they're not doing that. They say they want it, but they're not doing it. I did a survey with United for Health. Yes, we want standards, we want standards. They're not specifying it in the procurement documents, and if you do not, Qualcomm doesn't have to make it with the standards, right? Neither does Apple, neither does Google. They will provide it to you in the easiest way that they can provide it to you. It does not necessarily have to be standards-based. Okay, let's go into some specific projects. United for Health. United for Health's goal is to scale up chronic disease remote monitoring, I'd say clinical workflows. They were required to use the same system architecture and clinical workflow in each region for participating in United for Health. I don't know about you guys, if you've ever tried to get a bunch of doctors to agree on a workflow across 14 regions in Europe, thank you, Panos Stopoulos, MD, he did it. He made them all do it. So they all have agreed upon a clinical workflow for a specific disease state, either congestive heart failure, diabetes, or chronic obstructive pulmonary disease. They did take into account the possible disparate levels of technology and infrastructure available in each region. and there is limited market in the region for telehealth projects. Here is a sample architecture for congestive heart failure. They have the lady with the cat in her lap, and she's going to have her blood pressure, her weight, and her pulse oximetry measured. It goes through Gateway. It'll go to a server, some type of a regional telehealth center that can either be outsourced or government provided. And then based on the information as it's analyzed in the telehealth center, that will send messages to the specific caregiver that needs to act on the data, or they don't have to act on the data, right? No inundation with data with the clinicians, only when they need to act on it. Now let's go to the other project, Smart Care. Smart Care is another European project, and what they're trying to do is to come up with integrated care models. And Matteo Puzzo, I think, is going to talk a little bit about this tomorrow. They are saying we not only want to have remote monitoring for clinical diseases or chronic diseases, but we want to include the social care element. And we wish to try and have a common ICT platform for that. I'm here to say that we still have, I'd say, some cultural issues that need to be overcome between the social care realm and the clinical care realm before we can get to an integrated technology platform. In fact, there already is an integrated technology platform. Here, the technology's there. It's a matter of the cultural approaches coming together and agreeing on how we're going to have combined workflows. Any way, you can see what they're trying to do, go from conventional care to what they call smart care, integrated care. This is my version of what they're trying to connect. Everything possible that you can measure in the home, plus a social component, plus emergency services, onto one platform to go to get the attention of anybody who is responsible for providing that service. So as you can see, this is a much more complex situation, lots of interfaces. Here is their one pathway in Smart Care. I hope I got the right picture, Matteo. This is integrated home support after hospital discharge. So basically, they're going to enroll a patient in the pilot, and then at home, whatever type of care they need, whether it's social or clinical, then that would be provided for, and the communication would occur across the ICT platform. And then again, this is a pilot, so if they end up in the hospital, they'll be treated by the hospital services. If not, then after the time of the pilot, they would kind of come out of this integrated pathway for smart care. The intention is for some of these regions, this is the way they will be doing business after the pilot program is over, because there's some serious restructuring of their infrastructure that needs to happen to provide this. Much more complex with regards to standards applications, clinical and social requirements, and you would use a combination of IEG profiles and continuum guidelines that can be used. So here you go. Here's an example. This is, I had to write the work package report with the standards that should be applied to the smart care. There were probably 6 pages of lists of standards, just because you have so much going on with care coordination between informal carers, social workers, clinicians, patients, family, everybody. So, interestingly enough, somebody's written a standard or a profile for that. Somebody's done the hard work. And I know there's some horrible acronyms there, but if you go to the IHE website or you go to Continuum Guidelines, they've actually identified this. And I didn't even mention this on here, but they've also done a lot of work continuing on security and consent management. General findings regarding standards used in telehealth projects, especially these European ones have been involved. Where the data is transmitted electronically, network transmission methods are standards-based, while messaging and data formats remain proprietary. So they'll use Bluetooth or Wi-Fi or the mobile, because it's easy, right? It's there. It's Qualcomm. We can provide you the infrastructure. I consider Qualcomm the ramp to the network. They will provide that information technology and telecommunications and networking infrastructure, but specific to healthcare, that's really where the healthcare industry needs to define that. Because the infrastructure also provides support for all the other industries, auto, government, everything. When integrating different types of care pathways, you need to define common workflows and areas for data sharing, and that's where the smart care is talking about. You need to find out what's common between the different cultures and then use that for data sharing and standards. And there remain important legal and regulatory barriers. Mr. Olson was right, the standards for data security and privacy are very wide across Europe. Norway is one of the most restricted, and they've had to lock down some of their home devices. Summary, my last one. Am I doing okay in time? All right, good. Interoperability, again, you want to be able to connect without extra work, right? You want to drive towards semantic interoperability. If I send you a data or a piece of information, I want you to understand what I'm saying, not just I sent you a data and it connected and got sent. Use of a standards-based approach helps to decouple acquisition decisions and drive down costs. This was based on the statement of information technology companies can change their products in 6 months, medical device companies not so much, 6 to 7 years. And you need to include interoperability language in procurement and standards to send a message to the market. If you're a buyer, you should demand this, because in the long run, it's going to be easier for you. And lastly, healthcare organizations can define the standards unique to their industry. So the data and messaging that's important to you, that's where you have the most control. You'll only have influence on the other ones because there are other industries that have demands on those particular infrastructures. Questions? No? You all understand this now?
We see the danger of getting lost in translation.
What? We get lost in translation?
No,
okay.
Not in translation there. Your translation.
Thank you.
So, do you like any questions to be done? But he's sure that we should summarize these ICT topics in the final part of this session, right? And so there is no doubt there will be more time to discuss this point. And obviously these two last lectures are really integrated, they could be really integrated in some way, and see if there is any match up of private sector and what really the public service needs to do. Anyway, next speaker is Nicolò Girolimetto, ICT and telemedicine, a real working example of integration of social service. As for the other speaker, if I do some desperate sign, it means you are getting out of time, right?
Thank you. Good afternoon. I am a medical doctor of Italian Telemedicine and the Health Society. And this presentation is in collaboration with Massimo Galletto, Managing Director of Softech Engineering. So, firstly, the expectation for the future. A significant increase in chronic diseases, progressive aging of the population, a reduced family caregiving capacities, a growing need for residential and home care services, and especially a growth of specialist hospital care. From SIT's point of view, critical issues are problems with care continuity from hospital to community, lack of integrated care pathways, no standardization, no platforms integrating the various actors involved, and the most important thing is the complexity of the social service and healthcare networks. And about complexity, I want to show you a real example of the complexity. This is a real map of the complex network in the area of Bologna. And each box represents a different actor of the system for example, hospital, social services, home care, and so on. And I think that we have a similar organization of all over Europe. But how can we integrate social services and healthcare? Well, we need to overcome cultural obstacles, policy integration at both central and local levels, and appropriate legislation, of course, especially on the privacy issues, and high-quality cross-cutting ICT platforms. So, it's necessary to upgrade from electronic health record to electronic social and health record. But how do we do it? It's a good question. Treatment plan must be focused on the individual, not on the funding channel, like in Italy now. Social services networks must be integrated with healthcare networks. Individual authorities and professionals need to interact with other actors involved in the process. And a system of genuine care continuity from hospital to community must be created. Of course, first we have to build the network outside the hospital. I'd like to show you a working example in the Bologna metropolitan area of post-hospital follow-up care and the integration of social service and healthcare networks. So, in the Bologna metropolitan area, there are 11 hospitals, 54 towns, 6 social and healthcare districts, for approximately 1 million inhabitants. Our example is based on ACT platform, currently in use, called the Garcia Wii. This is a web system on open source platform, which is currently in operation in Italy and soon in France, but it can be replicated in different European countries. It can be integrated with pre-existing systems, allow real-time communication between the different actors involved, so it can be created a genuine social healthcare network. Enables the creation of integrated pathways and enables fully personalized records. In Italy, electronic social and health record is called fascicolo socio-sanitario elettronico. And we talk about the Garcia Wiz FSSE that is structured in three levels. Section, for example, social services, general practitioner, home care, and so on. Each section is designed to accommodate dedicated page for the individual areas. For example, for a medical doctor, case history, functional, nutritional history, and so on. Each page is designed to accommodate customizable indicators and specific scale. But the most important thing is each section may be updated by a single professional profile and released for readership to the other profiles. Of course, guaranteeing patient confidentiality. Here we can see a screenshot which represents the first level of the system. We have highlighted the profile of a general practitioner, in Italy MMG, the profile of home care nurse, and the profile of the social worker. This is the post-acute care pathway in Bologna. The hospital activates the local operational center, which coordinates hospital to community transfers and manage waiting list and patient placement. Out of the hospital, there is a very complex organization because the operational center, just a moment, The operational center has at least 3 options as possible. Okay, thank you. As possible, 3 destination for the patient: intermediate care, home care services, and residential services. Now, I'd like to show you a practical example. Laura is 75, is widow, one son living abroad, economically disadvantaged. She has a chronic disease like hypertension, cardiovascular disease, and she needs a transfer because she has a stroke. She needs a transfer to a residential service. This is the Laura's post-stroke care pathway in orange. We can see the different actors are involved, from the hospital through the local operational center. She is transferred to the intermediate care, which is directly in communication with the social services and local health authority that organize the transfer from intermediate care to the residential services. Now, let's have a quick look to the instrument used to the job. This is a screenshot of hospital chart with a medical profile and a lot of information for medical doctor. Here we can see the match of demand and supply in local operational center, which is integrated with social services that we can see here. So, this is very important, the different actors work on the same platform for the same process. Now I'd like to give you some data about the care continuity from hospital to the community. In this chart we can see a progressive rise in patient discharge. And here we can see more data about care continuity, and we can see that there is a 65% increase of beds compared to a 72% increase of number of patients transferred. And from this we can understand that there is a higher turnover per bed. And average days of hospitalization is decreased by 7%. In summary, here are the results. So, there is a networking between all the actors in the system, a pooling of patient information thanks to a unique shared platform. There is no paper involved. There is more patients. There is higher turnover of bed. There is a reduced average duration of hospitalization, and optimized discharge pathway, and the creation of personalized care pathways. So our future goals are assessment of clinical and functional outcomes for patients, an identification of specific patient profiles, an increased personalization of care pathways, and appropriateness of care settings. So, in conclusion, from SIT's point of view, there is a need for integration of healthcare and social care, an interoperability between different platforms, safeguarding the confidentiality of sensitive data, European support for the development of e-health, and ICT support for caregivers and case managers. Thank you.
I think that since these lectures are really highly integrated, they all go around with similar points, and we are going to address in common these points in the next, call it round table. We call it round table. It's really, just the simple way to enlarge the discussion. And so I would like to invite here Maria Dolores Nunez, Enrico Tardocchi, and Samuele Baruch for taking part in this round table, in which I think Maria Dolores has some slides, am I correct, to introduce the points, and then we will have some time also. The Europe Assistance, another private company, who is introducing their own assets, and obviously open for the discussion on these ICT and technologies and solutions for health.
Okay, thank you very much. It's just a few slides in order to introduce my point of view. First of all, I would like to congratulate the organizers for this fruitful event, and also thanks for the opportunity to be here in order to share with all of you our experience and also learn from you. The demographic transition in Europe is the greatest challenge that Europeans face. Okay, is the main challenge of European countries have to face in a way. Increasing life expectancy is the main achievement of the European societies. This is due mainly for the technological and medical advance, but also due to our European lifestyle, and because our excellent healthcare system and social health system. But this led in turn another challenge for our economies and also for the welfare state. Okay. Okay. In the field of health, that's the context show us an environment that evolved to countries with aging people and also with some chronic diseases. Okay, in the case of Catalonia, the number of aging people is around 17%, and in the case of patients with chronic diseases is around 20% of the total population of Catalonia. But the use of this the primary center, primary care centers, is 80% of the use of primary center is directly related with chronic disease. And in the case of the use of the hospital, 60% of the hospital admissions are related to this chronic disease or chronic patients. Perhaps it's time to start thinking in a new models for chronic illness. In the case of Catalonia, we a new model for remote healthcare has been developed in the framework of the health plan of the Catalan government, and it's because we think that ICT can address new models and new business models, a new way to provide healthcare and social care. The goals of this remote health model is increase the resolution capability in home for patients with a proactive and quick and specialized response. Also to provide tools for professionals, for patients and for caregivers, in order to improve and increase the participation and the involvement and the empowerment of the patient in their own health, and the implementation of this remote healthcare in order to improve the management and optimizing the use of the health resource. In other words, in order to use less this health resource. Until now, the results we achieve are that 100% of hospitals in Catalonia use the electronic record. 95% of the hospitals do not print the radiological breaks. 93% of the hospitals and also the primary care centers are still are already involved in our shared medical history of Catalonia, and up to 50% of the hospitals are using remote diagnostics. This is important because this figure go up 5% in the last year. Around 44% of the hospitals start and use teleconsultation, and only 30% of the hospitals using some telemonitoring to track patients. We have good scores, and we are very proud about this, but that does not mean we have some other duties and homework to do. Among these is to add some intelligence to this system in order to help health professionals, social professionals, and also caregivers and families in the work. Promote the use of mobile devices and mobile health, and in order to facilitate the accessibility to the system, and also provide and assure the interoperability of all this record. Another kind of challenge is the integration. We talk all this afternoon about the integration of different levels of care. We have good scores in hospital and for acute patients, but for primary care, social care, mental health, in our case, I think also is very important to integrate the data for mental health, and why not from some data from private insurance in order to have a full complete medical information about the patients. Another kind of challenge we face is to increase the offers of products and services, and diversify the kind of products and services in this very complex ecosystem we work, because we work not only in hospital or in primary care centers, because we are also working in a home with many other devices in home, and also to promote the public-private partnership in order to define new business models, because we are awareness that the technology, in many cases there is the willingness, and there is the need and the expectation, but it's difficult to define a very good business model in order to make and transform this challenge and in a business opportunity. And from a social point of view, the other challenge is to define and design a system, a citizen-centered system, and support all this citizens, and support the patient empowerment. In this two later aspect, we are involved in a European Med project called Wider. We have a poster there in the poster room, and we can invite you to join us in the poster. The main focus of this project is to help SMEs companies in the Mediterranean, in the 7 regions in the Mediterranean area, to find and to define new products and services addresses to help and improve the aging at home in a healthy and independent way. Well, we are in the way, but there are a long way to go, and there are much to learn. Thank you very much.
On this line of collaboration, public and private, I invite now a representative of Europe Assistance to introduce the company and what they can offer in terms of health services and addressing challenging in health independence.
Good afternoon. Good afternoon. We didn't prepare any slide because we just wanted to introduce an open discussion, but just a couple of words about Europa Assistance. I'm Enrico Tardocchi. I'm working in the product marketing, and Samuele Barco, my colleague, is from Medical Operations Center. And probably part of you know very well Europa Assistance. Europa Assistance is the company who invented the assistance 50 years ago in the travel area, but now is a global player that provide personal assistance services in several areas, and one of these is the health. Europa Assistance is part of an insurance group, Generali Assicurazioni, and is very interested in providing new care services in that area, which is our vision, which is the point that we see in the global environment that is marked by profound change in technology and in society. The point for us is that improving the people's life quality and well-being means giving an easier access to assistance, giving an easier access to local, personal, and human services. So we speak about technology. For us, the technology is the enabler of the assistance, but we think, as in previous speaker, it was underlined, we think that the assistance is really a crucial point, because we have to be with the client, with the customer at all the time. So from the information, from the orientation, from going through the support and the care. How? And this is the other interesting point, trying to offer with a double business model these services. First, as an insurance, and in the second way, as a service company. So at the moment, we are trying to develop a wide range of care services that are sold through our shops, online, or through our website. Going deeper in the services, the information and the orientation is the first step. We think it must be captured and well qualified. So we prepare, we launch a platform. Maybe you can put in the background the slide, the platform. No, sorry. Okay, we launch this platform that is a website where there is a double where there is a double aim. One aim is to be a referral point for who is looking about info, about prevention, about a kind of qualified magazine. And on the other side, this portal is an access, an easy access to the assistance. How? With the simple services, probably you know better than us, so clinical file, ask an expert, second medical opinion, medical passport, personalized checkup. So trying to make easy the way a client can get in touch with a doctor, with a medical center. And to do this, we have to adapt all the internal process, because we start as an insurance company, and we are still an insurance company, and become a struttura sanitaria, so a sanitary structure. So we have been certified by the IESE of Milan, that certified us as a company that could provide assistance by distance or at home. I leave Samuele to continue and go deeper in the operational medical center area.
Buonasera, parlerò italiano con mia facilità. Come dicevamo, Europa Assistance è oggi riconosciuta come struttura sanitaria, e questo vuol dire che abbiamo passato un lungo percorso di certificazione e di riconoscimento da parte dell'autorità sanitaria
che in Italia è l'ASL di competenza, per cui abbiamo sostenuto e riconosciuto tutti i processi sia strutturali che organizzativi necessari per prestare assistenza sanitaria al domicilio dei nostri assistiti e assicurati. Di conseguenza oggi noi siamo in grado di prestare, come fossimo un ospedale, come fossimo un poliambulatorio, la stessa assistenza al domicilio. È ovvio che da questo anche la telemedicina e la teleassistenza per noi è fondamentale, perché da sempre noi siamo stati pionieri come Europa Assistenza in telemedicina e teleassistenza. Già nel 2003-2004 abbiamo cominciato i primi approcci alla telemedicina ancora con apparecchi analogici, videotelefono, e di conseguenza poi mano a mano siamo passati su piattaforme più evoluti, e questo ci ha permesso negli anni di fare numerose sperimentazioni. Abbiamo fatto numerosi progetti con delle ASL per pazienti dimessi successivamente a ricoveri per ictus e altre patologie. Abbiamo fatto anche sperimentazioni in rifugi di alta montagna in Val d'Aosta, piuttosto che altre esperienze a favore di disabili che sono ospiti del Comune di Milano all'interno di strutture dedicate, oppure anche in situazioni dell'emergenza calda, quindi a favore di anziani che vivevano da soli. Questo ci ha permesso negli anni di affiancare la telemedicina a tutto un progetto di assistenza. Come dicevamo, l'Europa Assistenza è leader dell'assistenza e ha iniziato 50 anni fa a farlo come mestiere, e quindi abbiamo potuto affiancare questi supporti di telemedicina e di teleassistenza a quello che già noi facevamo da tanti anni. Oggi noi lo proponiamo all'interno di nostre polizze, che quindi in ambito di una copertura in un post ricovero, in assistenza domiciliare, diamo anche la possibilità di avere al domicilio la distance care telemonitoraggio. Grazie.
Right, so we discussed this afternoon in this session the role of ICT in developing new approaches to old problems, and the situation looks fairly complex. The need of standardization has been stressed. The services offered already by companies, just remind Qualcomm or I remind Europe Assistance and so on, are quite well developed, but I think there is the feeling, and my personal feeling is that there is a real need of standardization and coordination, as someone of the speaker who's watching me now has stressed. So, is there anyone who wants to intervene on this point? Because I do know that you are rather tired. Nonetheless, it's not the end of the day, you know. It's not the end of the day. Please, you want to say something?
Valentina Solfini, I'm a medical doctor at the healthcare service in Modena. Not only standardization, I would like to put on another point of view about efficacy evaluation and evaluation of impact on different points, economic point of view and efficacy of the healthcare delivered with this support otherwise in the current way.
Absolutely. In fact, I always ask myself the question, how is it possible that in USA you spend about 18% of the what you call it, the GDP, right? And while said we can do it fairly well, Italian is doing with a little bit more than 7%. And as far as I do understand, I mean, taking out Singapore and some other small states, Italy is apparently one of the most efficient health systems in the world. So obviously we are not happy at all with it, but then we have always to think how much unhappy or more unhappy are other people about it. Please, Stuart. At the end of the day, I will know all your names.
Okay, so this is, well, it's kind of a question and also a comment. There are two things. So one is a question about what you think an efficient model of standardization is, because there are many different models. And say, for example, in avionics, then there's a competition, the product wins, and then people have to either use it or produce something which is identical. This means that things automatically interoperate, whereas the standardization process that's very often followed is something where you can have compliance without interoperability. So I wonder what the speakers would like to say about the models of standardization that they advocate, and whether they think the models of standardization that they advocate actually guarantee interoperability.
I think it's Bridget.
Sorry?
Am I correct? Okay, stand up.
I agree with you. For us, absolutely, the
standardization.
Yes, and in our case, the standardization for us is also a very important matter, and we are working in a group with specialists with ICT, but also with the specialists in doctor de Colegio de Médicos de Barcelona. I don't know what's the translation in English. Medical Council, that is the Medical Council, in order to identify the key parameters to standardization and to certify this is a good software or also a good app related to health in terms of safety and in terms of efficiency. And it's not an easy solution, and we are just working on it. In the case of apps, we have also with the Medical Council, with our Health ICT Foundation, and with the mobile, because we are very at Barcelona. We have also the mobile work competence center, and with this also competence center, we are defining a marketplace for apps related to health in order to help the people to choose or to identify. But it's also a problem, but it's not solved because in the Commission also for CE mark is not clearly resolved when a software is a standalone software or not, is medical device or not. And this is a discussion, and I think it's necessary to clarify this point and work on it.
Thanks. Anyway, really, let me do some comments also on this issue. European Union has an opportunity to adopt an interoperative system. Am I correct? We should do it at least, these few small things in Europe, instead of, I do understand Scotland or Catalonia or Northern Italy who want to be a single state, whatever, I don't know the reasons, but on the other side, I would really say, whatever it is, we should have adopted a single system, at least for these kind of things. The situation within a few times in Europe, obviously, will be that of millions of overaged people. And so there must be a change in attitude and the way of treatment. This is so clear to everyone, unless we expect something which never will happen. Please, Bridget, also, I'm happy you want to say something.
To go to the map from Scotland, you're talking compliance versus certification.
Compliance versus interoperability.
Well, no, there's two types.
You have three things which comply
Yes.
to standard, and none of them will interoperate. It's a
Right.
very common problem.
Okay, I didn't want to go into this detail, but okay. All standards have variable parts to them. So the difference between Continua, the integrated health enterprise, and some other things is that Continua actually does not allow you to have variability. If you want to have plug and play, you have to constrain and agree on you will be doing these certain things. Integrating the healthcare enterprise allows variability. So you would probably get 80 to 90% interoperability. My message was, okay, you can shake your head, that's fine. 50, okay, whatever you want. It's not going to be 100% plug and play, okay? All right, that's fair. With regard to, I think, healthcare, and you're even going to see that with your Bluetooth. How many of you have an old Bluetooth versus a new Bluetooth, and the two Bluetooths don't talk to each other, right? It's still a standard, it's just a different version. So that's the product cycle, right? I think what the healthcare industry needs to do, and I think they're getting there, it just takes time, is to agree upon those things that are very specific to their industry. For example, if you're a cardiologist, pretty much a heart rate is a heart rate is a heart rate, right? So call it the same thing, same standard piece of terminology, heart rate. Also, you could say it's the heart rate from a non-invasive blood pressure machine, or the nurse did it with their hand. Context, of course, is important. But even that is not there yet. The standards are there, but they have not been adopted. Somebody in charge has not made the decision to say, you will do this. There was a European project called EPSOS that tried to come up with a cross-border discharge summary that identified these items as standard data and messaging items. I understand it was a nice project, but it has not been implemented because the legislatures and the politicians and the people in charge have not said, you will do this, I will not buy this unless you do this. So you can demonstrate all you want, but you have to have the political will and the money and the decision makers say this is what happens. But the problem I see with some of these European projects is it's hard to get the politicians' attention because they've got a lot of things going on. So if the healthcare community can agree, there are standards there, and you can move forward. And then you won't just have, like you said, compliance that really doesn't bring around interoperability. Does that help answer your question in the direction you wanted, or no? All right. Anyway, I'm done with that.
Right. Anyway, I'm happy the discussion of today's discussion on ICT. We were a few minutes ago about to close this session, but reignited by the common interest. I think this is definitely a very common interest. Anyway, let me now take a decision from top down, either side, 15 minutes, not more than that, all right? Because we have still the last session on robotics, which I think again will be quite interesting. So it's a long day, but very interesting.
Good afternoon.
So, Pastor Licia, can we start? Please, Dr. Rudolph.
Good afternoon. Firstly, I would like to thank the organizers to invite me to come to this meeting. I come from Ljubljana, the neighboring country, so it took me 4 hours to come here. And although there is no border anymore between Slovenia and Italy, there is a huge difference in the situation regarding telehealth and telecare here in Italy and in Slovenia. But anyway, I would like to share with you some experiences, and hopefully we will find some places of interest or some opportunities to collaborate in the future. So, it's a nice country. It's a small one, having just 2 million population. But anyhow, we deal with similar problems as all other European countries. There's a small difference between us and the others. We are the only country having named a word love in the name of the country. So that's very nice, in particular, if we compare us to Spain, which has Spain in the name, so it's much better this way. So all the challenges actually are also ours. You have mentioned them before, so I will not enter them. But there is
the future is also not very bright for us as in Italy. So up in 2060, we all will need a lot of money to cover the needs, social care and long-term care needs. So we are almost the same. We will need 3 times as much money as we spend today, and Italy will need twice as much money as you actually spend for long-term care. The question is where we would be the most efficient if we approach with our telehealth, telecare system and solutions. If you look at the expenses for telehealth, for healthcare in Europe, in 10 countries of Europe, then with the age, all the systems actually, although they are different from the organizational point of view, and they all use the same amount of money to cover the expenses for healthcare. So here it is not much to do. But if we go further on to the long-term care, so we have huge differences in the expenses. Here you have Italy, and here you have Scandinavian countries. So firstly, any positive result, and here may reduce costs for long-term care very much. And in addition to that, we should somehow look into Italy's Italian system, what they do, that they have so low costs for long-term care. So there changes are needed just because our systems in Europe are not sustainable anymore. So we should change something. And the European Commission has said, well, firstly, go into home, go try to provide care at home, try to implement solidarity. This is the most important fact. And of course, use ICT to support services. So I'm to talk about the quality of life of chronic patients using telehealth systems. So what is the quality of life for senior citizens of Europe? So according to this research, it is independence, health, social care, and safety. And these are the areas where my company, the micro company, has been working now for 25 years. Firstly, we were in Telecare, now we moved to Telehealth as well. The house of future, the home of future will be different than it is ours. So huge companies like Samsung, they think about the home of the future, but this will not be only a place to work, a place for entertainment, but it will also be a place where we want to feel ourselves safe, where we want to be supported, where we want to be healthy. So we need to add something to that models that the larger companies provide. We also should change the existing care models. So why this is for the primary care the only model we've been using so far. We should change it, maybe so that support is provided at home, and that existing current medical workers, they do their job in a different way. So we will also need to think about the institutional care, which should change from this traditional models here into living communities, or even further, we may think about the virtual homes for elderly, where every apartment, every house will be a part of this virtual home of the future. So we need, of course, we need solutions, but above that we need services. So the question is how we will use such toys as these are mobile phones, how we will use activity monitoring system like this one Fitbit, how we will implement into the health service of the modern age our medication compliance devices. What we will do with the existing measuring devices, will this be a part? So for the rehabilitation purposes, we need different type of sensors that will be a part of the rehabilitation at home, not only at the institution. We will use for sure also the virtual reality for rehabilitation if appropriate. And we will additionally use also new technology developments, what it could be also, let's say, smart textiles with sensors and so on. And this great challenge presented to us, actually the big players on the global market, they came with the products, but they had not come with services. So it is an opportunity for us to use these products and to implement them into our services. So what will be the services of the future in the fields of telemedicine, tele-nursing, tele-rehabilitation, mHealth, and so on? So we should think about that. In particular, we should distinguish between two groups of services. One is based on the business-to-business model, where we have healthcare specialists involved only, and patient is excluded. And the other group of services that are based on the business-to-patient model, where we have the patient involved directly with the healthcare worker. So the model for that is that one. We have a provider of the service here, and we have a user of the service having strong support from carers, and in between all the infrastructure. And there are different already known services that may be proposed or may be built based on this, but we need a strong support. The idea itself is not enough. Coming from an idea to the service is quite a long way, which should be called, actually should be supported by some money. But this is not the end of building a service. With this first service setup, we need to have professional validation, promotion, we need to improvements, we have to measure impact, and this is all the story we have to go through if we want to use services. So we expect that all primary, secondary, and tertiary users all will benefit. So everybody in his or her its own way. And we also believe that primary direct users will also benefit, and there are some expected benefits for them. I'm trying to skip over some facts that I will come to the end of my presentation in the time limit. So in Slovenia, we have some home care services, but only a little bit more than 1% of the population being 65 and over is covered by that. So we had 4 Telecare centers, all of them are closed now. And we have just one telemedicine service available regionally. So this, when the Europe measures the efficiency of a country or of a region, it presents you the reality. And the reality for us is here. For Telecare solutions, after 20 years of work in Slovenia, we have this situation that there's almost no traces of Telecare in Slovenia, better in Italy, and also, of course, better in countries having a long tradition in this area. But all of those in a circle, we started in 1990, and Spain is doing quite well in this, and the Netherlands as well. So the start was equal for all of us, but the results are different. So when supporting chronic patients, Sorry. We work in the United for Health project as well. Bridget mentioned before this project, and we take care for diabetic patients and patients with congestive heart failure. So we had to involve 600 patients, 200 heart failure, and 400 diabetic patients. Altogether, the project will actually follow for 1 year almost 15,000 patients. So we can consider this project to be the largest in terms of number of patients being involved for such a long period. So the model was presented by Bridget before. We use, this is for cardiac patients here. They use 3 types of devices to measure blood pressure, to measure weight, and to measure oxygenation. One of the most important things here is family. So support to patients using this is very important. We use mobile phones to send information to the regional center. And the second important thing is that people are called by the operator if something goes wrong. So I will talk about this later. So that's a snapshot from our portal where we have all the data on pulse, on pulse, blood pressure, oxygenation, and weight here. And this is a place where a physician writes his report, his opinion, and this opinion is reported to patient. So for diabetic patient, almost the same model, and also this is a snapshot. So measurements before the meal and after the meal here, let's say. So we have actually the observed group and also control group of patients being being equal in numbers of patients. And we pay a lot of attention to the process of involvement of patients into the study. So they are personally addressed. They are all what we do with them is in written. So they get everything in written. They sign the agreement to written consent, and they are equipped with written instructions and so on. So we also plan to make satisfaction interviews at the end of the project, but not only for those who actually pass the whole 12-month period, but we do also interviews with those who decline to participate, and also those who withdraw from the study during this period. So far, out of 300 patients, we are having now only 1 patient withdrawal, but the inclusion rate is 90% if a doctor addresses a patient, and 50% if a nurse calls a patient and asks him for participation. So such reports are used for professionals and also for patients. And we plan to inform also patients on that, but so far we don't do that. So these are, for the moment, reports for professionals. And there have been some organizational changes made, but we are now in the phase of recruiting patients, so we haven't paid so much attention to the organizational changes in we are pleased that the patients organization actually see an opportunity for them to be involved in this. So they are equipped with promotional sets, and they go around for promotions, and they are even ready to go to patients who cannot participate because they are not capable of managing the device. So they are ready to go home and have such a patient. So what are comments that we get from them? So I'm happy because I'm supported. some said, now I get more attention than before, because somebody calls me if something goes wrong. So this support is better than the traditional support. So, and even further, it's good. I'm supported more, but I don't need to travel. And one of them said, well, my mother can be now alone at home, because I know that if her health status deteriorates, somebody will call and will manage and will help her. So this was the presentation. Now I'd like to make some advertising for other work we do in Ljubljana in my company. One is too much, 50 seconds. So one is telerehabilitation. We actually do some rehabilitation at home, providing patients with educating or with exercises on video that are downloaded, that are accessible in the cloud, and they are visited by a therapist every 2 weeks. So they prepare themselves to enter the traditional hospital, rehabilitation at the rehab institute. So this is the simple view they have on their tablet, and this is these are snapshots from Skype. So all they have to do is just to press 3 times on the tablet, the same button. After 14 days, the therapy changes, so they use the same button, although behind the button there's another content. So this last thing is we also develop a service to support patients with hemophilia at self-treatment at home, so they have to report on the medication, the quantity, the type, and the reason for that. And so this is the model for that. We use mobile phones where they actually just select, and within a minute they report on the use of very expensive drugs. So each injection costs 2,000 euros, and one therapy in 1 year costs 200,000 euros. So it is worth to follow the consumption of such medication. So thank you very much. I will not talk about the difficulties we have, and the obstacles and barriers. We may discuss this in private. Thank you very much.
Thank you, Brother. Always in a top-down decision, what we do at the end of the session, so there will be no question now, but at the end of this session, we will all sit here together, all the speakers of the last session, so we'll be invited to come here, and so we will have a discussion at the end. So I invite Christine Petioki, Technological Support for Persons with Dementia. Christine is from Vienna. Please. The audience is all for you.
Okay, thank you. The project which I will present now is a part of the SPACE project. The SPACE project was a support to patients through e-service solutions, and I would like to draw your attention to the website address here. And if you go to this website, you will find a link to our film, because we also made a nice film. And maybe if you need a break, you could look at our film, which is maybe quite nice. So much at the beginning. We carried out this project in the Central Europe program of the European Union. Here you see the region, including Emilia-Romagna, of course. The overall objective objectives of this project were, according to the Central Europe program, to contribute to social cohesion in the Central Europe region, and in this context contribute to social cohesion with a space of e-health, telemedicine, and ambient-assisted living. And more closely, more specifically, we had the objective to implement a platform for target group specific applications. We called it for pilots, and it was in 4 cities. It was Ferrara, Vienna, Brno, and Košice. And even more specifically, it was our target, our objective to find answers to specific needs of certain target groups. These target groups were persons with respiratory diseases in Ferrara, with dementia diseases in Vienna, with multiple disabilities in Brno, Boskovice, and not only this medical approach, but also a very social approach, namely performed in Košice. They defined the target group as older persons at risk of social exclusion. And another strand of this project was that we referred to a previous project in the FE area. You can read more about it on the poster over there, about all of this. These were the partner organizations. The coordinator was ENEA here in Bologna. The coordinating organization and the coordinator, Gianluca D'Agosta, is also with us today. You can also ask him afterwards about the project. Yes, and talking about this consortium, it was a mix of universities and other research institutions, service providers in the field of services for older persons and persons with disabilities, and also public authorities. So we really were able to build a partnership which can build a model for cooperating successfully in this field, I would say. This fact, which I mentioned before, that both medicine-related applications, for example in Ferrara, and support of social inclusion and self-determined living were identified and tested in the project, made it necessary to explore also the terminology which we used. And work was carried out in all 3 areas, e-health and telemedicine and ambient-assisted living. And then we created we used a more generic term as e-assistance or tele-assistance. The Vienna pilot, which I'm going to present you now, is more attributed to ambient-assisted living. So I would like to talk about the Vienna pilot. Our objective was to identify, adapt, and provide useful technologies for persons with dementia, and to enhance their quality of life. We wanted to tackle specific problems and specific events in the life of persons with dementia due to poor short-time memory, for example, due to disorientation, really incidents that happen in everyday life. And to find them out, we had to involve users, and we talked about carers today, users and carers from the very beginning. Of course, many colleagues who were involved in the project from the outset are practitioners and also knew a lot about the situations of persons with dementia, but we had to involve the users themselves, really to find out what are specific incidents, what are specific issues which might occur in everyday life with dementia. Yes. Of course, The user involvement presented quite a challenge with this target group, but as I said, it was indispensable. Without user involvement, we couldn't have worked. And one side effect of our work was, of course, that we also wanted to integrate the solutions which we would find in the daily work of therapeutic and social work with this target group. Very shortly, I want to have a look at the term dementia. Whom are we speaking about when we talk about dementia? Because dementia is not a disease; it's a syndrome, and and there are many diagnoses which we can subsume under this term dementia. But it wouldn't, for us, it wouldn't have been very useful to talk about diagnosis. We prefer to talk about everyday behavior or characteristics of behavior of persons, and so we refer to the model of Naomi Feil, who developed the so-called validation method in the, I think it was from the 60s of the last century up to this century. And so we had a very broad approach to the target group. It ranges from persons who are in the first phase, who construe a different reality to the common reality, for example, who might think that their belongings were robbed when they don't find them. And other characteristics of later phases of dementia would be to mix the present with the past, and to look for the village where they spend the youth, but they are living in a major city and so on. So, or the withdrawal from any communication in later phases of dementia, where people become even non-verbal. We also work with persons who were non-verbal already. And this diversity was reinforced by a cultural diversity, because in Vienna, of course, we had much immigration, so we also had persons with dementia diseases and migration backgrounds. Yes, when we approach persons with dementia and when we want to involve them, I also already said that it presented quite a challenge. We have to be aware that we cannot expect straightforward answers and formulations when we ask them what they wish to do. We have to observe them, we have to show empathy, we have to understand also symbolic non-verbal behavior. We have to speak to carers, to relatives, to friends and other trusted people. We have to try out a lot of things, but without exerting pressure on the people. This is most important. And proceeding from these observations, we did not seek to develop the overall solution, the big solution, but we just wanted little solutions, modules, so to speak, a modular system which would not intrude too much on the person's lives, because they wouldn't have liked too much changes in their everyday life, which and we know that in this stage of life, in the early age, in the late age, also in the early age, as a small child, but also in the late age of life, we don't want too much changes, and it might increase our disorientation if there is too much change. So we have to find little solutions which don't interfere too much in everyday life. This is most important, and which don't interfere in daily routines too much. And finally, 5 test cases. Before we found test environments, daycare centers for senior citizens, supported flat-sharing communities, and at a later stage of the project, also in private housing. Daycare centers and supported flat-sharing communities in Vienna are part of the long-term care system, what Kai talked about before. So we we work there, mainly in the daycare centers, because people with nursing needs, with dementia, spend their days there, but they live in the private flats. And finally, these 5 test cases emerged. Orientation support, which provides the possibility to support persons who have a tendency to lose their way without restricting their movements in case of emergency. The second test case was preventing dangerous institutions, which refers to a system which activates an active RFID alarm when a disoriented person gets in a potentially dangerous situation. The third test case was the talking key, which is a reminder not to forget the key when leaving the flat. This is for persons who are more independent still. Then the brain stimulation test case was a very complex test case where people themselves worked on PCs with different programs, also with the internet. I will show this later. And last but not least, finding things again, which helps finding the previous mentioned belongings again before thinking, oh, I've been robbed again. Maybe it's a help to find it again. Meaningful things which get lost. Okay, and the first test case was the orientation support. On this slide you see the device which we used. We tried out some devices, but we decided to take this one because it's very small, it's light, it's pleasant to be touched. You can fix it to the belt or to the you can carry it in the handbag, you can carry it around the neck, however you want it. And it's not so heavy as these bracelets, which are also on the market. And it's simply a GPS, GSM localization device, which we used with iPhones at the beginning. It's just sending an SMS with the iPhone to the localization device, and the localization device gives feedback on the where the person is at this moment. And at a later stage, we used a smartphone with a SIM card and SMS gateway mobile application together with the office computers. And this is a scene from the test. The persons went individually and in small groups for walks, and were asked before to take the localization device with them. Mostly they were asked if they would like to help to find out if this device is feasible for finding people again, and we said, of course, we like to help. We like to help the European Union because it was, I said it was an EU project, so we said the European Union wants us to find out if this makes sense. And said, yes, we'd like to be involved. We do it. And if the person wanted and were able to push a button on this device, they did it, and they could get into contact with the caregivers at the daycare centers via the speakerphone. Here are the caregivers, and they see the location of the persons first on the display of the iPhone and later on the PCs. This is the visualization and administration portal which we had at the later stage of the project to find the people on the via the PC. And this is a bit of feedback of the test persons, very friendly feedback. It doesn't bother me in the least. And where do the voices come from? Because it was with a speakerphone. Or now I will always know where my children are. So it was a bit the opposite of what was really happening, but they understood the sense in a way of what we are doing. I only use it to please you, of course, or I'm pleased to help you, like this. The purpose is, of course, not to monitor the persons round the clock or to not surveillance, but really the possibility to reach them in cases of emergency. Because it's a real... Do I have to speak up? it's a real project, a real problem if they get lost for the caregivers. So the Austrian Act on stay in homes, and also daycare centers and friend-sharing communities are in legal terms part of the system of nursing homes. Regulates precisely under what conditions the user's freedom is allowed to be restricted, and such devices are freedom restricting devices. So we also had to really follow this law, and the main thing is that we have to protect people individually, but not as a collective. Doors have to be unclosed. So when we wanted to prevent dangerous situations later, a test case which also allows the localization of persons within a specified area or building, we cannot work with GPS and GSM because in a building this won't work, so we expanded the technology to active RFID, and this technology also gave us the possibility to protect the persons individually. And this test case was installed in a daycare center which specializes in work with disoriented with persons with dementia. And here we see a gentleman who is about to go away, but the colleague could localize him and ask him maybe to stay a bit, and he agreed and he came back. And on the screen she got the alarm. And the system is that there are two safety areas. One is the foyer of the daycare center. When people enter the foyer, and this is already a dangerous area for them, an acoustic alarm is given from the active RFID tag, which is placed in the daycare center. And the second security stage would be the garden door. Okay, the third test case was for persons who are not so disoriented yet, who live at home and who have maybe a poor short-time memory, but who want to maintain their independent lifestyles. And the talking key is a device which gives a message when you leave your flat without having the key with you. It gives you the message, attention, please take the key with you first. This is what you can hear. You can have a familiar voice, if you want it, who tells you that. And immediately afterwards, the key ring, the key ring, which is also an active RFID tag, gives an acoustic signal so that you can find it easily in the flat, quickly and easily in the flat. Here's again the systematics. There's a door sensor over the door. The door sensor detects whether you have the key with the key ring with you or not. And if you have the key, nothing will happen. Everything will remain quiet. But if you don't have it, the door sensor sends a signal to the reflex repeater, and the reflex repeater here, and the reflex repeater sends this message. It gives this acoustic message, attention, please take the key with you first, and at the same time gives a message to the key pendant, to the key ring, and the key ring gives the signal. And here's a lady trying it out in her flat, and you see there's no installation necessary, no special installation necessary in her flat, and it's quite small, and it's not and you don't need a computer with it.
Kristen, can you reach conclusion because we are out of time?
Okay, yes. Brain stimulation is work on the PC. People did a lot with personal memory books, for example, individually and in groups. We had a special application. Our colleagues made a special application for persons with dementia. Here you see some examples, how it looks like. And the last test case was finding things again, where objects were equipped with RFID tags, and by touching a symbol on the screen, the object could be found again with an acoustic signal, so the object would be easily found. Okay, so I switch all the other videos and figures, switch all the other slides. Thank you for your attention.
I think the message went through, and otherwise we will still have time at the end of the session. So, European neighborhood is big, and so I'd like to hear what our northern cousin has to say. Torbjörn Svensson from Lund University is invited to give us the next speech.
My slides first. Thank you for the invitation, and thank you for pronouncing my first name so well. That's actually a hard one. Torbjörn is an old Vikings name. Thor is the god of thunder in the Vikings sagas, and Björn is bear. And I actually had a doctoral student from the US. He always called me Thunder Bear. So I'm going to speak a little bit about Innovate, which is an AP7 project, and also especially the part where I and my colleagues are involved. And what we are setting out to do in the work package that I'm working on is to create an ICT-based tool for linking housing to functional capacity. So this is not really e-health. This is more about proactivity, to help people to say make adjustments to their housing situation before they are actually running into bad health. So first a few words about Innovate, the full project. The mission is to concentrate the highest possible quality of scientific activity. I mean, you always say that. Together with stakeholders, which is really relevant in this case, and we should have active participation of the older people to help us to do these social innovations. The objectives is to develop, implement, and evaluate 4 potentially cost-effective social innovations. I'd say something about each and every one of them very shortly. It's to create a social innovation web-based platform to address the critical barriers to implementation of social innovations, and especially to have a focus on the new member states. It was mentioned by Kai Leistenring about social innovations, and you also gave us a definition. I don't know whether that's one that you're using in MOPAC, and I think there are as many definitions of social innovations as there are researchers and politicians within the EU. And so one of the things is to try to define what really a social innovation is, and maybe try to look at the standard for calling something a social innovation or not. So that really falls under the first work package. What we're working on, and that I will go into in more depth, is the user-driven housing for older people. The ICT-based social support for carers of older people, that's led by IRCA here in Italy, in Ancona. And they are building a platform for helping carers that take care of older persons in their own home. And that will be available through the Eurocarers organization on their homepage, and it will be translated and be available in all the EU languages. Improving obesity-related outcomes in old age, that's led by Sheffield, and obesity often runs in families, either genetically or by social influence. So what they're doing is that they are kind of using intergenerational connections between kids and their older family members, or you can not even belong to the same family, but you can connect on the social network and try to push each other to be more physically active. The long-term care in motion is at the University of Heidelberg, and where they're trying to improve the physical conditions and the physical capacity of long-term care patients by different types of devices. Among them are the game situations. And then, of course, then we have the knowledge exchange and transfer. In our work package, we have, of course, partners all over Europe, and most importantly, I think here, as we are in Italy, is that we have the Italian National Research Center on Aging working with us. So what I didn't say in the beginning was, I mean, we said that we are going to provide some kind of device for older persons where we would connect or make a connection between their physical abilities and their housing situation. Because depending on our physical status, we run into different type of barriers in our environments. So and I will gradually move towards an app at the end. But we didn't know that when we started, because we have different type of research circles or focus groups in Italy, in Sweden, Germany, and Latvia, where we were trying to have older persons or their user organizations tell us what they wanted from a device of this type. And that was, of course, to establish the user requirements. So we had these research circles. We used the same type of protocols. They were the same number of individuals. They could ask specialists to come in and talk to them if they ran into some certain problem, if they wanted to have more information on a certain area. And then we collected these data, put them together, and this is the core set of user requirements for an ICT tool that came out of this research circle. So one was to detect, evaluate, and provide information on potential accessibility problems in current and available housing. So that's available housing in the marketplace. Suggest or recommend possible actions to address identified accessibility problems. Where do I turn if I have this and that problem with a barrier in my home? And of course, it's obvious that the interface should be easy to operate and understand. So then we need a stock of apartments to be able to say, these are the different types of problems that you run into. So we were training individuals that were working with us to test these instruments that we're having, and that's based on a big EU project that was run formally. We used the protocol called the Housing Enabler, where you have a long list, 160 items of physical functioning in the individual, and then you rate the apartments as well. We can skip that. It's basically that we ended up with a lot of typology of apartment. I mean, if you go into an apartment block, you find that one apartment is exactly as the next one. So what we're doing is to develop this prototype for a new interactive tool. And we are using, as I said, this database that we have, and that's built on data from all of the Nordic countries, from Latvia, from Germany, and the UK. And it holds thousands of individuals. And from that, we have calculated an algorithm which sits in the cloud, which kind of fits different type of functional profiles that individuals have with the type of barriers that you would eventually encounter if you have these type ailments. So to build this app, there is something called Democenter-Sipe, which is a interdisciplinary type of programs that they run in different universities, where these slides are really bad. where students from different disciplines can come together and get a task from a company or a university, and they have to work with a real life solution. If they come up with a good solution, you pay them a fee of 2,000 euros. And that automatically gives you a release on the protocol that they have developed. So we use that, and then we, thanks to Sony and Ericsson breaking up, we had a very high-profile person from Ericsson who was, or is, working for something of a salary that was quite below what was expected, I'd say. So we're building now a test version, a first version of this so-called app, and we will do usability testing on individuals in Sweden and in Latvia. It is on a tablet and is built on Android, and I'm going to show you some pictures on what it actually looks like. So this is the front page now. I flies all over the screen here. Sorry. So this is what meets the person in the beginning. So they can ask for information. They can also have an instruction video on how to handle the app. If you look at the top, you can see this is question number 5. I took an easy one. Do you have poor balance? And you answer yes or no. The red one on top is where you have said that you have the problem. The green ones, you don't have the problem. The yellow one is that's the question you're wrong at the moment. So you do that for all the different type of questions that are asked you concerning your physical abilities. Then when you have done that, the algorithm is calculated, but you can of course choose to save your profile and exit, but you can also ask for, and you can click on potential barriers, and that would provide you with a list of the potential barriers that you're encountering given the profile that you're having. So say that you're living in your apartment, you could easily walk around, see if you have them, and the optimum is, of course, that we provide the place in the municipality or wherever it is where they should turn to have help with different types. Sometimes you can have loans, sometimes you just have expert advice, but that should be available in the application. So then, of course, you can also say, so this is when you want to stay in your present apartment, you want to do adjustments, but you can, of course, also say that, no, I want to look at what's available out in the market. So you say, search apartment, and we have a huge database of available apartments. In this case, it's in Riga and it's in Lund. But anyway, that would give you a list of available apartments, so the number on the list, the address, the number of floors, the number of rooms, and the monthly rate of that apartment. Do you have some spray? So anyway, this is the way that we're envisioning this at the moment. The thing is that when we're testing this for usability testing, it will be an iterative process. We will get back, we will do redesigns. Am I doing fine for time? Power break. I'll go slow, so I use it. No, so it's not an available product yet, but we can see that, for instance, in Sweden there is something called Hemnet, or Hemnet in Swedish, where all listed apartments or houses are listed that are available across the country, because all realtors, they use this platform. And if we, like today, we have all apartments, all houses have energy declarations. If you could have accessibility declarations, well, maybe if a realtor finds out that this is something that really creates a market for them, they will eventually do that. So I think, we think that there are quite a lot of different options available here and for a future of getting this off. Thank you.
So I invite now for the last speech of the day, Reinventing Modern Textiles for an Aging Society, Amengual. And comes from Francis, Leopold Francis University. Right? Sorry for the misspelling.
Okay, so hello everyone, my name's Anne and I'm from the University of Innsbruck Research Institute for Textile Chemistry and Textile Physics. And today I'd like to present to you Reinventing Modern Textiles for an Aging Society. So just to briefly introduce our institute, so we're actually located in Dornbirn, which is in the Vorarlberg region of Austria, which isn't in Innsbruck at all. It's 180 kilometres away from Innsbruck. So the explanation for this is Vorarlberg had a very prominent textile industry, and today there are 70 textile companies and 150 embroidery companies in the area. So you might ask why I'm here. So the university, we are undertaking a project called Textiles for an Aging Society, or as we call it, TAGS, and it's a European Commission funded project as part of the FP7 framework. So the project is running for a period of 4 years, and we're currently coming to the end of our 3rd year. The TAGS consortium consists of 10 members from Austria, Italy, Germany and the UK. And we consist of research institutions, technology transfer institutions, end users and manufacturers. So I'm sure you're all aware, so I won't go into much detail, population aging is increasing in Europe. So the reason for our project is to create textile innovations to help with this problem. At the moment, there's a fragmented situation between researchers, manufacturers, end users, and social and medical care institutions. So the purpose of our project is to act as a kind of facilitator to bring everybody together and to identify the latest specific textile requirements of the elderly in care institutions and transfer these into products and look at ways we can incorporate these in the manufacturing chain. So our project has 4 main topics. The first one is bedding, so duvets, pillows, bed linen, etc. Secondly, clothing, so everyday clothing, specialist clothing, adaptive clothing. Hygiene, so different aspects, reusable and disposable products, things such as wipes, incontinence products, ostomy bags. Also, we can extend this to kind of towels and flannels. And lastly, therapeutic textiles. So there are many therapies which exist which can have the support of textiles. For example, warming and cooling textiles, compression stockings, electrotherapy, light therapy. So what I'd like to present to you today is some findings from our first 2 topics of research. So the research on bedding textiles finished in June 2013. So we collected information by issuing questionnaires which were completed in selected care homes across Austria, Germany, Italy, the UK and 1 care home in Slovakia. And the types of things we addressed were: what are the existing functions and properties in bedding textiles? What are the desired functions and properties in bedding textiles? What materials are currently in use and what would be the preferred types of material for use? And what we found, just to give you a brief overview, is the biggest complaint with bedding textiles was their hospital-like appearance, in which case this would make care facility look institutionalised, which isn't nice for people residing in these homes. Secondly, that cotton is the most commonly used fibre in bedding textiles. And another point to make is we asked carers what they wanted. They wanted cotton. We asked what they were using. They were using cotton. So then this leads me on to my next point, which shows there is little expectation in the functionality of bedding when other materials are concerned. So we also asked carers to prioritise what was important for them, and comfort was the #1 priority for a resident. So again, through textiles, better comfort properties can be achieved through moisture control, less friction, the handle, kind of how the textile feels, and warmth properties, and all these can be achieved in part by fibre selection. Secondly, concerns the bedding system in general. So bedding systems could be more intelligent and use things such as sensors, aid movement devices, or devices which can decrease pressure. Manufacturing also creates a barrier in any developments in this area. We found that bedding is often viewed as a low technology product. Much of your bedding is now produced in low cost labour countries, therefore cost is often a difficult hurdle to overcome. And lastly, washing. So in care homes, the bed sheets, they have to undergo a harsh washing procedure. So obviously the lifespan of the bedding must be considered when purchasing a product. So there are some adjacent projects which have been initiated as a result of tax. So the first one is a bedding preferences study which was completed in a care home in Dornbirn. So the point of this research was to look at the colours and design in place to move away from the hospital-like appearance of bedding and to gather the opinions of people currently residing in care homes and for those who aren't, because everything transitions and those people that aren't currently in care homes will at some point in their lives probably be in a care. So it's important to gather all these opinions together. And the result of this is a new care home was opened in Dornbirn, and the choices are now implemented as the bedding moves there. So another project is the Netzwerk Waschbären Sensor Textilien project. I'm learning German. We like to call it News Project. And this looks at embroidered sensor textiles in bed sheets. So the bed sheet will feel normal, you won't feel there's a big bulky sensor, and the point of it is that you can wash it. And also this measures the resistance when the bed becomes wet. And this will send a signal to a carer, which will then get the carer to come and check the patient, the resident, sorry. And this supports carers in their round-the-clock duties, and it also gives the resident a better quality of sleep because they're not being disturbed every hour. So just moving on to our clothing topic. So we finished our research in this area in June this year. So the graph is an example of a literature review we completed, and the red line at the top shows the number of references which relate to clothing in general, and the blue line at the bottom shows the amount of research which has gone into clothing for the elderly. However, elderly is not specific to elderly people, but also to processes, so the line at the bottom is kind of a misrepresentation, even still, showing that there's not a lot of research which has actually been involved in elderly clothing. So again, we collected data by issuing questionnaires in the same countries as before, and some of the results that we found were there's very little in the way of useful technologies in everyday clothing, so there are many improvements which can be made in this area. So number one, there's no wearable technologies in use. You can take the sportswear clothing, for example. There are many types of gadgets or things that you can now get in sportswear clothing. This same technology could in fact be applied to elderly clothing Elderly clothing is often considered unfashionable, so no research really moves forward in this direction. Ill-fitting garments. From a carer's perspective as well, we found there was little or no knowledge about specialist elderly clothing suppliers. Again, with the lifespan of clothing, much clothing available does not withstand harsh washing procedures, and existing clothing does not support declining health or bodily conditions, such as incontinence or loss of mobility in limbs. So, a project which was actually born out of one of our TAGS meetings is a project called Vesta, which is a company which is based in Medina. And Vesta looks at creating adapted clothing based on user needs as identified by hands-on caregivers or nursing professionals. And again, they're structured very similarly to us, in which they're trying to bring together clothing designers, manufacturers, healthcare professionals, and end users to actually push this forward into the manufacturing chain. And the good news is they're retailing at the end of the month. So if you would like any more information on this, please look at their website. Again, with my literature review, the graph ended in 2013. I just wanted to point out that there are actually things being done to progress clothing for the elderly. So some companies have fashion campaigns fronted by older models, and things such as realistic 3D mannequins for correct body sizing are now being used. Okay. So we began work on hygiene and personal care textiles in June earlier this year. So at the moment, research is ongoing, but however, we already have seen some interesting results, which I wanted to share with you today. So, a new questionnaire was issued, and I'm going to take a case study from the same region, Vorarlberg in Austria. So we looked at a care home in Lustenau, which is an industrial town, compared with a small farming village in the mountains called Amengual, which is actually 32 kilometres away from Lustenau. And what we found was, Lustenau was formerly an affluent textile industry, so many people that are residing in the care homes now have a very high standard of what they expect in terms of hygiene. So they expect to be very well presented at all times. For the ladies, even hair and nails done, for example. Amengual, small farming village in the mountains, hygiene standards, let's say they don't mind a bit of dirt under their fingernails. So you can see, with only being 32 kilometres away, there are differences in the hygiene standards, and I guess this is a typical example, which I imagine is the case for many regions across Europe. So, that brings me to the end of where we are with our project at the moment. But before I finish, I would just like to point out that one of our TAGS biannual meetings is taking place alongside this conference, and not at 17:40, in 20 minutes, I guess.
Right, we say it now, but yes, we do.
Okay. We're going to
reallocate the time.
Okay. We have a TAGS meeting room across the courtyard, and you may have seen these coloured cards, which one of our partners, Licia, also mentioned today. We're trying to collect your ideas or thoughts on current hygiene or therapeutic textiles, what the problems are, what new ideas you might have, any kind of thoughts in this area. We're going to collect all these together now and have a discussion to see how we can move the project on in the last year. So if any of you are interested in coming, I'd really like to invite you, and I'd be really interested in hearing your thoughts.
And just a second, could you please stay here then for a second, and also the other speaker may join here, please. But see, if you need to go to this, do you think the brainstorming start now, or can we delay it in 10 to 20 minutes? I think it's correct. Possible? I also invite Marta Ribeiro. Okay, Marta Ribeiro from Navarra is addressing ongoing care in biomedical devices.
Thank you. It's late, and I try to show you, to tell you about space, in particular about the experience of Ferrara. Cristina Diocchi has just shown many slides, so I can move on. I show you some data of population, I think to be useful. Sorry. Useful to understand the context. In the addenda US of Ferrara, we have an aging index of 236. That is 40% more than the regional average. More, we have a population density of 136.5. That is quite less than the average of Region Emilia-Romagna, is a little less than 200. So this results in additional costs for healthcare offer. And in this context, we have carried on the pilot, Ferrara pilot of SPES project. The target is represented by patients affected by chronic respiratory failure requiring long-term oxygen therapy, and in some cases non-invasive ventilation. In this pilot, patients were provided with a system that can monitor in remote the health status. Sorry, again, I am attentive. And this can enable a more efficient use of medical aids and finally improve the localization in healthcare service. These pilots, in general, overall, guarantee, in our provision, telemedicine to all healthcare users and a technology user-friendly. General aims were to better support elderly people, to have a speeded up diagnosis and therapeutic care, to reduce, this is an important goal, mobility of patients, but the physician also. Easier procedures for better service provision, and an easier management in health risk prevention. These patients are critical patients often, and the prevention of exacerbation is important. These are the devices. This is one of our patients, and this one is the system for oxygen delivery, TOM, the stroller. This is an Iconia, is an Iconia tablet with ADSL 3G connection, an oximeter with Bluetooth connection, a spirometer. This was used in the second phase of the pilot. The data were collected, transmitted to medical server, and we have also, sorry. questionnaires for the perception of quality of life and respiratory condition. These are the functionalities for user. Take and view data for medical measurements, compile and view questionnaires, send and receive email messages, and also video conference with Skype and agenda. For the professionals, view medical measurements and questionnaires, of course, add information about the patients, and the setting of alarms. Briefly, some results about the two aspects mainly. Healthcare service in accessibility. I underline before space we have a higher rate of unsatisfaction, and after space you see the bar is higher, of course. About health condition satisfaction, it's less clear, but I told before, patients are critical and it's difficult to have a satisfaction about the health status. Otherwise, you can see that the blue bar decreasing, and we have a neutral state after space. In conclusion, for the patients, we have a safer and serene state. They perceive that specialists monitor constantly the health condition, and patients are able to self-monitor their health parameters, and is an important goal for us. Overall, is an empowerment of the patient in these patients is an important point. For the professionals, medical doctors are able to monitor constantly and by remote patients' parameters, and particularly can define better the follow-up agenda according with the health condition priorities. The future. SPES has closed a few months ago, June. We are going to start another project. It's called FISTER, and target patients are patients not requiring oxygen, but COPD patients followed at home, but also in ambulatory section. And this a smart patient and a part of a keep. Today we have not Mattias de la Cala, Dr. Mattias de la Cala, that is a co-worker of mine. Thank you for your attention.
Thank you, Marco. Now my task is not easy, right? So after a long day, to stimulate an audience is not so easy, but I think that what we heard also in this last section was really interesting. Domotics and ICT, if you allow me to join the two sessions, is really something extremely relevant for the future and in an aging population. And so this is really the subject that we would like to discuss to finish off today. Afterwards, as you know, you're invited to some poster viewing, and then this will be the last fatigue of you. Is there anyone who would like to introduce the discussion? Are you all very happy? Please. Theodore.
Thank you very much. I got encouraged to make a rather clinical question after the presence of Dr. Lodi. I think that all the results were from EU project, right or not? Oh, he's back. Okay. I would like to ask the experiences about the patient's behavior exactly. I mean that the patients in the project are, let's say, different. In what terms? In terms, they are few in numbers, first. They don't pay, second. They are especially pampered. And except of all this, when we present, I'm familiar with the good words that Drago mentioned. But when we present these results to experienced clinical audience, we are not quite convincing. What is your experience, your point of view?
You mean?
Well, not only you, or any other individual.
Well, in my case, I didn't want to present any data, so we still are collecting data and will come with objective clinical results when our project, United for Health, is over.
Okay, I don't mean exactly the numbers, but the behavior of the patient. Is it similar with the patients of everyday clinical practice? That's a question. I don't mean that I have specific numbers.
Well, again, in addition to clinical data we collect also other data, also the user satisfaction, the user experience. So this will be the result of the project, which will involve roughly 10,000 persons, people, patients. So we think that we will get a strong, some strong conclusions.
Of course, the behavior of patients or of clients is different within a project than in a everyday situation. I think we have to bear this in mind all the time. But we can learn very much from the project because how we approach the persons, how we accompany them, how we support them. We would need this accompaniment and support also outside of the project, also in the post-project phase if we want our results to be sustainable. In our project it was most interesting because we worked with so many people who never touched a computer before. And they got access to the internet, and we had the feeling that we bridged the digital divide a bit because we worked with non-verbal, very old persons who one gentleman started to speak again in connection to what he saw on YouTube, for example.
Almighty computer.
Yes, so it was really amazing for us, for the therapists and social workers who are not so ICT affine as well. So either. So I think it's but it remains a special situation.
Stuart Anderson would like to make a question.
I wanted to ask what you thought it would need in order to produce evidence that would justify scaling up from your work, whether you think it's good enough already or whether you want to do more. I mean, because I was interested in the last speaker's data that he showed, because certainly in some work we've done in Edinburgh, you get very significant placebo effect on the patients. And our experience for the physicians was the very reverse of the statements that you put up. They were concerned about being sued because they missed things in the data. They were overwhelmed by data, and they didn't know what to do with it. So that was the experience in a 150-person telemonitoring trial. So I just wondered, because here we're talking about how do we scale to the point where we get enough evidence that we can make a major change in service delivery, and what would it take to do this?
Anyone like to answer here?
It's really a difficult question.
The data were not extended to the physicians, general practitioner, I mean, the data were collected and viewed by the specialists. And the patient collect the data, and the data were included in the system, but the patient own not know the mean of the measurement. And if you need a electronic fascicolo sanitario elettronico, insomma, FSE, to show this data to the general practitioner, and it has been included in a system with the mission of the National Health Service.
Right, for sure, these electronic recording systems for patients, again, I mean, for instance, Italy, they have developed, and each region adopt a different system. So, again, in a short time, we will have 21 different systems, and I'm afraid in Europe, probably, will be another 20 or 100 different systems of electronic filing, and this might be really a big problem with the time. I mean, by the way, I'd like to make a question to you. I mean, an issue which is coming up forward. I mean, this type of intervention should tend to diminish the cost. But it looks to me that quite often that they, at least for the time being, they are going to increase the cost. Am I correct? Can you give any indication? I mean, the matter of cost, as it was addressed before by Theodore, is correct. I mean, this is free now. Europe paid. But what happens if really this is going to be the point? Still want to interact with me?
I wanted to make, I mean, this is very crude. I wanted to make an observation, which is, if you look at things like telereferral and telemonitoring, introduced in health systems which are, say, in less developed countries where the existing health system is not so developed. So, for example, there's quite an interesting study from Brazil in World Health Organization journal, where they have very clear cost benefits and very clear quality benefits for the patient, because the telemonitoring is fitting into a space where there is no service at the moment. The problem that we have in our systems is we have good services there already, and ethically we cannot take those away to then observe. So we have to have a methodology which somehow either controls and takes away the effect of this, or we have to take a big step somehow, and not many people want to do that kind of thing.
Any other comment on this point?
Well, we are in the phase of investment, and we should calculate the costs on the long term. So let's say after 5 years after this investment period is over. The next thing is maybe we should step off of the paradigm that we will reduce the costs, but surely we increase the quality of care by that. So patients who were actually, let's say, not cared at all, let's say in chronic patients, the only contact with the doctor was every 6 months, are now cared. They are in contact with when they need some kind of support. So better care is what we have gained out of those projects.
I would like to get a comment from Anne. What do you think about this point? I mean, is this clothing system or whatever really going to take an advantage, or perhaps, I mean, in Vorarlberg they use those lederhosen all the time, and they could still fit until all day, right? So they last about 50 years.
It's difficult to say because older people don't necessarily want kind of e-clothing, smart clothing. What we found mainly is that just adaptable solutions in regards to lost mobility in limbs, so having a bigger sleeve, for example, would be a lot more beneficial than having something which monitors or senses kind of everything on you.
Right. Anyway, you didn't pay attention up to now to the cost benefit of the project.
Not this aspect, no. Our project has been more sort of a research into the different types of things available. Cost is a barrier because the more technological things are, the more expensive they are. So again, for an elderly person buying into this type of product might not be so attractive.
If I may, I would argue that as you get older, you're going to want the wearable sensors. You have a totally different generation. Well, but as people who are used to being connected to the network and having sensors, they're going to demand these products in the future. So you've got a cohort, an elderly cohort, they've never had this before. They're probably just amazed, at some of the things that are available to them. But I propose, and you see this actually in the use of applications and in the way that younger people think. They think, I'm connected. Whereas older people think, oh, I guess I could be connected, right? So I think you're going to see changes over time as the cohorts and generations get older. They're going to demand more of the sensor capability and the interconnected that information technology brings. So right now, you kind of got people who are just happy to have clothes on. So.
It is. Also, Joana wanted to say something. So, can we speak? Okay, Marta, sorry. I didn't learn all of your names.
Still, just a comment regarding the cost efficiency, because we were looking into that regarding mHealth, and everyone says that would be more cost efficient, but there are no really studies or bigger studies regarding that. And the only thing that I found on that topic is a very recent study from Pricewaterhouse that actually looks into all the savings, that direct savings and then indirect savings, but already only from the direct savings that implementation of mHealth can bring into Europe by 2017, considering all the cost of implementing and having a workforce that is professionally educated in a way that they can provide those services. It shows that even so, it's really cost efficient. So continuing your idea, it will be able to provide better care, but also at a slightly reduced cost, according to them.
Okay, let's go along with the. Okay, Rob.
Can I just make one comment and really support what you said, Richard? I think that the word is really cohorting, because we look at older persons, but we don't take into consideration enough the issue of cohort, because there is also a kind of a time lag in introduction and scaling up and getting the products or the interventions in place. So we're actually researching one cohort and we implemented it in another cohort. And I think we have to take some time for that, and I think we also have to think on whom are we actually addressing in the research or in the type of interventions that we're doing. We need to I think, look at a kind of a half a cohort back, so to speak, to be able to have the right audience for what we are trying to implement.
I would like to add one sentence to the question of finances. We in every step of the project we thought about affordability. I think we really have always to bear in mind whatever we do, is it affordable for our target group? Because we know that poverty and old age have something to do with one another, And so it was one important criteria in our project, that in the Vienna pilot, that we only took products which are affordable. Or that, for example, the application for persons with dementia, which was developed, is an open source application, so it's without licenses when it is used further.
Okay, I just, on the cohort issue, I think one interesting group to look at is the quantified self movement, because I think if you look there, you have a group who are very highly motivated. It hasn't spread, yeah. In fact, many quantified self groups have died out. We had one in Edinburgh for about 2 or 3 years, and then it just died away. And I think there's a very interesting thing about this continuous monitoring in terms of the state of mind that it puts you in. And actually, I mean, I just come from a conference where people were talking about this, and actually people find they have very unpleasant side effects in terms of your persona. Yeah. So I think there are real issues, and looking at the sociology of the quantified self group would be an interesting thing in terms of the cohort. And I know they're a special cohort, but they're very highly motivated, and they don't manage to maintain it.
Right, please tell them.
If I can provoke a little bit more Stuart's previous point of view, I would like to add that according to our experience within a country, within a society, these kind of services, despite the fact they are considered as luxurious ones, are for sure more cost effective to less socially favored parts of the society and more psychologically resistant to the disease. Like the remark of Stuart in less favored countries. It's the same within a country, within a society.
Stuart, you like to throw bombs. But what I meant by cohort, I did not mean being continuously monitored 24/7. I meant being comfortable with the use, with more use of technology outside of you in your life than you would have otherwise. For example, I had a joke that if the Wi-Fi went out, who here would know how to use a pen, a piece of paper, and be able to go back to older techniques for functionality? I think that's what I meant by cohort, and not the self-identified Gartner hype cycle, kind of the early adopters, all that kind of stuff. So I just wanted to clarify what I meant by that. But that, you know, you're dealing with people who have seen so many different things in their lives regarding technology, and their expectations of that technology are very different based on their age and their experiences through these technological life cycles.
All right, so it looks for today we had enough. So we thank you, all of you, who endured all the day, and obviously I thank all the speakers, those sitting here and those.
And thanks to the chairman.